Greetings, everyone. Welcome to the PAASE Fireside Chats, Episode 19, Ivermectin, Pros and Cons in Light of COVID in the Philippines. I'm Gisela Concepcion, President of the Philippine American Academy of Science and Engineering. And on behalf of my co-host, Dr. Manolet Dairit, and the whole of PAASE, I welcome you to this fireside chat. For more information about PAASE, you can
Ayun na si Austin.
visit our website. May I request everyone to unmute, please? To mute, please. PAASE tagline. PAASE's tagline is Agham at Kaalaman para sa Bayan, Science and Technology Outreach to Philippine Regions. So I would like to recognize the presence of some government officials and their representatives
Yun na nga.
of PAASE, members of PAASE and the NAS, the National Academy of Science and Technology, and of academe, participants from the private sector and from media. May I request everyone to mute, please? The goal of this chat is to provide us some light, clarification, and not contribute to the confusion and frenzy over ivermectin. I would like to point out the link to the congressional hearing. It's posted on our chat box. The overall goal of this chat is to find ways to move forward. So at this point, I would like to introduce our distinguished lineup of speakers, and I thank them profusely for their willingness, for their courage to share the facts they know, their analysis of it, and their views regarding ivermectin. We will request Dr. Mantaring, our first speaker, to speak for about 20 minutes, and the rest of the speakers to speak for about 12 to 15 minutes. For the rest of the audience, may we request you to type your questions in the chat box. Kindly keep the question simple and not complex, and we will try to get the answers from our speakers also in 2 to 3 minutes. And this is in the interest of equal time and opportunity for everyone. If you would wish to speak, kindly raise your hand and you will be recognized. Our first speaker is Dr. Jacinto Blas Jojo Mantaring, who is professor and chair of the Department of Clinical Epidemiology of the UP College of Medicine. He is a clinical professor and practitioner of pediatrics, neonatology at the Philippine General Hospital, and he's a chair, UP Research Ethics Board, and DOH Single Joint Research Ethics Board. The next speaker will be Dr. Joy Arabel Castillo Fontanilla, who is chief of the section of epidemiology at Asian Hospital. She is the head of the Center for Weight Intervention and Nutrition Services at St. Luke's Medical Center, Global City. She's an associate professor of pharmacology at San Beda University College of Medicine, and she's American and Philippine board certified internal medicine, endocrinology, diabetes, and metabolism. Our third speaker will be Dr. Benigno Iggy Agbayani, Chair, Department of Orthopedics, Manila Doctors Hospital. May I request everyone to mute, please? Medical practitioner, arthroscopy and joint reconstruction, co-founder, Concerned Doctors and Citizens of the Philippines. Fourth speaker is Dr. Benjamin Benji Ko, medical practitioner of pediatrics, infectious disease and clinical pharmacology at UST Hospital, Asian Hospital, and Cardinal Santos Medical Center. Our fifth speaker is PhD Dr. Leodavico Vic Ilag, Chair Scientific Officer of Xerion Australia, Chief Scientific Officer of Horizon Science from 2011 to 14, and Chief Operating Officer, Patrice Limited from 2004 to 7. At this point, I would like to give the floor to my co-host, former DOH Secretary, former Dean of the Ateneo School of Medicine and Public Health, and former Director of the Department of Human Resources for Health, World Health Organization, Geneva, from 2006 to 2012, Dr. Manuel Manolet Diary. Thank you.
Thank you very much, Giselle. And good morning, everyone. Good morning, friends, scientific colleagues. We ask our speakers to consider the discussion guide, which has been advertised. And essentially, there are 5 themes that each speaker could dwell on during their discussion. The first would be the clinical and epidemiological studies focused on the safety and efficacy of ivermectin for prophylaxis and treatment of COVID-19. That essentially is the main theme for today. And we want to get clarity around the safety and efficacy issues of this medicine for prophylaxis and treatment of ivermectin, of COVID-19. The second is the mechanisms of action for control of the virus, as well as control of inflammation. Third would be ethical issues around ivermectin use, particularly within the context of an epidemic and within the context of scientific controversy. Fourth, we'd like to look at the regulatory issues. FDA has issued certain statements. For example, there's no ban on ivermectin, but there's no use without FDA registration. So what's the way forward? And finally, clarity around specific ways forward, which we can actually sort of promote or propagate, hopefully to give channel to the debate and eventually find usefulness for this medicine, if at all there is evidence for it. So without further ado then, may I ask Dr. Jojo Mantaring to take the floor. He has 20 minutes to give us his remarks. Dr. Mantaring, you have the floor. Jojo, are you on mute?
Sorry. Thank you, Dr. Manolet, and thank you, Ma'am Giselle, for the invitation. I'll try to do my best to do justice to the topic that was assigned to me. I want it actually on record that I was only invited a week ago. And I think that if you had given me more time, I probably would have made a more detailed analysis. However, I believe that I will be able to use up the 20 minutes that was given, except that I will not be touching on ethical issues given the limited time, but I believe I can answer questions if it has to do with research ethics and not bioethics. I just want to verify that my slides are showing right now.
Yes,
Yes,
Judge.
thank you. So these are my disclosures. I'm the chair of the Department of Clinical Epidemiology and the chair of the UP Manila Research Ethics Board, as well as the DOH Single Joint Research Ethics Board. I am not an infectious disease specialist. I hardly take care of COVID patients being a neonatologist. In fact, I have never taken care of COVID patients. I'm not representing any interest group and I have no interest in any company that sells or manufactures any products related to the management of COVID. And I thought that I should start my lecture with why the need for clinical trials, because I intend to explain, especially to the non-scientists and perhaps the congressmen, why there is a need for clinical trials when making a clinical decision regarding the efficacy of treatment before I summarize the evidence from the literature. So why is there a need for clinical trials? So let me just start that if you had one patient who had COVID, who gets better after treatment with ivermectin, you still cannot conclude that ivermectin made him improve. In fact, describing the outcome of a single person after he has received treatment is called a case report. The problem with case reports is you cannot make conclusions for a population based on results from just one person. But a case report encourages other researchers to report their experience, perhaps to contribute to the body of knowledge regarding the effects of an intervention. Because why do patients improve after being given treatment? It could be the effect of treatment, of course, but there are other factors like host factors, their immunology, their general health, genetics, perhaps, and nutrition. Of course, there are disease factors, the dose of the virus, the virulence, especially now that there are several strains. They can even get better without treatment because that could be the natural progression of the disease. There are also environmental factors and socioeconomic factors. Now, if you have, for example, 3 patients, all who have COVID and who all get better after treatment with ivermectin, you can only conclude that intervention may have worked for the 3 patients described in this series, but you still cannot conclude for the general population. And describing the outcomes in more than one patient after treatment is actually called a case series. In terms of strength of evidence, a case series might be better than a case report because because it involves more people, then it becomes more generalizable, but you still cannot infer that they got better because of the intervention. As I've said, because there are other reasons or factors that will make them better. So if the issue is numbers, let's say that we did treat in this figure 30 patients with who have COVID and treated them with ivermectin, or you observed, no, rather than you treat. You observed 30 patients who had COVID who were given ivermectin, and you notice that at the end of treatment, 6 still remained with COVID. So 6 out of 30 did not get better. Then that's you might conclude that translates into an 80% efficacy. However, that's just a single population. If you happen to observe similar patients who were not given ivermectin, and in this group of patients, 9 patients did not get better. Now you have a comparison comparison of the outcomes among those who were treated compared to those who were not treated. So if 80% got better in the treatment group and only 70% got better in the control group, that's actually an efficacy of 33%. And that means that you can now conclude, or you can make better conclusions because you're doing it on a large number of patients, um, and you have a comparison group. And actually, If you observe groups of patients, this is actually called a cohort study. And now in large populations of patients, we have to review why patients improve. It could be the effect of treatment, but there could be differences in treatment, the dose, perhaps the duration, co-interventions. Co-interventions are treatment other than the treatment of interest that might influence the outcome. There could be differences in the host factors, immunology, resistance. There could be differences in the disease factors among these two groups who are observed. There could be difference in the environmental factors or socioeconomic factors. And there could be differences in how the observers define patient outcomes and the manner of outcome assessment. And that makes the argument for why we need a clinical trial. In a clinical trial, you get a group of patients with similar characteristics and you randomize them, randomize half the group perhaps to get the treatment, ivermectin, and the other half not to get the treatment, and look for the outcomes in both groups. And if it just so happens that the outcomes look like this, then you cannot say that there's a 75 or an 80% efficacy because whether they are treated or not treated, they have the same outcomes. And that makes the argument on why we should look for evidence coming from clinical trials. The advantage of the clinical trial is that the methodology includes randomization, which provides an equal chance for all eligible participants to be allocated to treatment or no treatment or the comparison groups. It equalizes the baseline characteristics for known and unknown factors. In other words, the socioeconomic factors are all controlled, the immunologic factors, the environmental factors. It controls for co-intervention. It standardizes the treatment, the dose and duration, and standardizes the outcome and outcome assessment. And so for this review, I focused my review on clinical trials or randomized control trials. Now, I won't dwell on this too much because this is not my area of expertise, but ivermectin is a US FDA approved, I think Philippine FDA approved likewise, anti-parasitic drug that is used to treat several neglected tropical diseases like helminthiasis, that's worms, scabies. It's also evaluated for its potential to reduce the rate of malaria transmission. Uh, and there have been reports from in vitro studies, in vitro or laboratory studies or studies done in animals or cultured virus, that it acts by inhibiting the host importin alpha beta 1 nuclear transport proteins. As I've said, let's not dwell on this. Maybe the other speakers can talk about this because I don't know what I'm talking about if I talk about this. It may interfere with the attachment of severe acute respiratory syndrome, spike protein to the human cell membrane. And with that, let me try to summarize the ivermectin trials. So I would like to acknowledge the Living CPG group. The Living CPG is a research group that is PCHRD funded. It updates the literature as new evidence becomes available, whether it's published or unpublished. For a while, I regretted agreeing to this talk when I thought I would be looking at maybe 3, maybe 4 clinical trials. And when I saw the volume of trials that I had to review, for a while, I regretted it. No? So the initial search that was done by the Living CPG, so I didn't repeat the search. I just asked the Living CPG group to provide me with what they found. When they did the initial search, they found 218 studies. After removing the duplicates and the initial screening, it yielded 18 studies for full text assessment. But eventually 9 articles were excluded for being non-randomized. Again, on the importance of a randomized trial. And 4 additional eligible trials were added since the initial search. So a total of 11 trials are included in this summary. I would like to acknowledge personally Dr. Jello Hoson, JB Basa, Jello Tampus, Ren Statting, and Howell Bayona, who are the team that was in charge for updating the living CPG for ivermectin. However, I did the summary myself. Hindi nila pinahiram yung summary nila sa akin. I had to do it myself. And so let's go and describe these studies, no, very briefly. So as far as the 11 studies are concerned, 4 are published and 7 are pre-published. The living CPG looks for both published and unpublished literature. And this prevents a bias called the publication bias. Now, to make sure that their search is comprehensive, it should include published and unpublished. Publication bias is a tendency for studies to have that have good results to be published ahead of the studies that are that don't have good results. No? So all the trials that I included in this review are randomized controlled trials, but they had varied dosing regimens. Ivermectin, the comparison group was placebo in 3 studies. There was ivermectin versus ivermectin plus doxycycline versus placebo in 1 study. Ivermectin versus no ivermectin in 3 studies. Ivermectin of different doses in 2 studies. And ivermectin versus hydrochloroquine in 2 studies. As far as methodologic quality is concerned, 3 studies were open label. There was no mention of blinding in 2 studies. 6 studies were supposedly double blind. Overall, I believe that only 3 studies were of good study quality. The differences in the characteristics of the patients, participants, all were adult who had RT-PCR confirmed SARS-CoV-2 virus. 1 study included 4-year-old, that of El Ghazar. 4 studies included mild COVID only. 6 studies included mild to moderate only. 1 study included involved only moderate. No study included severe. As far as outcomes were concerned, 8 studies looked at virologic clearance or load reduction. 2 studies looked at improvement of symptoms. 1 study looked at the duration of hospitalization. And 1 study looked at the time of resolution of symptoms. I would like to pause my share to share with you the summary of my findings in 1 big table. Unfortunately, I don't know if that table will be able to flash correctly. Can you see my table? So these
Yes,
are
yes, it's
the,
there.
okay, good. So these are the 11 studies arranged according to author. And I summarized whether it's pre-published, the population, the age, intervention, the dose, the outcome, the method, the outcome for duration of symptoms, and the results, plus notes regarding methodology quality like randomization, concealment, which is probably something that I shouldn't dwell on because the non-scientists in the audience will not appreciate these technical details. No? But this is the summary of findings table for the 11 trials that were included. And as you can see, they had varied, okay, so they had varied doses. For example, if I may, in this study of Ahmad, they did a 5-day course of 12 milligrams once a day for 5 days versus 12 milligrams once a day plus 200 milligrams doxycycline, and then every 12 for 5 days. The Chakur study was ivermectin 400 milligrams per kilo single dose. The Chakar was ivermectin 12 milligrams initially, then 12 milligrams after 12 hours, and 12 milligrams after 24 hours, without stating how long the patients were given the ivermectin, etc., etc. So the reason why I wanted to show this table was to show you how diverse these studies were, how heterogeneous they are, and that they really cannot be compared, no, or combined. The results really cannot be combined. So let me go back to my slides to try to go back to summarizing the results of the studies.
market online, no?
So let's look briefly at the results. So for the outcome of duration of symptoms, a med study looked at the median number of days. And as you can see, for the ivermectin group, it was 9.6 days with an quartile range of 7 to 11, or about 8 to 12 days. The ivermectin plus doxycycline had a median of 10.1 days with a interquartile range of 8.5 to 11.8 days. And the placebo group was 9.7 days. You can see that the ivermectin was practically the same as placebo as far as duration of symptoms are concerned. And the doxycycline somehow made the duration a little bit longer, but that's not statistically significant. It's just a few hours difference. So the study by Lopez Medina looked at resolution by day 21. And for the ivermectin group, 82% had resolution of symptoms by day 21 versus placebo, which was 79%. Again, no difference. Okay, for the outcome of viral clearance, Shakur looked at the proportion of those who became RT-PCR negative at day 7. And for the ivermectin group, 12 out of 12 or 100% became RT-PCR negative compared to 11 out of 12 in the placebo, in the no ivermectin group. And that's, of course, you can already see without looking at the relative risk that this is not significant. For the study of Ravikitri, who looked at RT-PCR being negative at day 6, ivermectin 31.6% versus placebo, forgive the wrong spelling, 23%. Again, this was not statistically significant. And for viral clearance, the study of Krole-Wiki showed that there was no difference in the viral load reduction between groups, and gives a graph that shows that the reduction in the viral load is actually proportionate to its initial viral load on day 1, and it decays at the same rate for both the control group and the ivermectin group. Still on viral clearance, Mohan's study looked at viral load reduction on days 3, 5, and 7. And as you can see on day 3, 3 or 7.5%, or 3 out of 40 in the RT-PCR had already this was the viral load. Only 3 had clearance, then 7 for the 12 milligram group, and placebo 7. Well, to make a long story short, these were not different in the ivermectin and the placebo groups. They were not statistically significant. So this is day 3 RT-PCR for the 3 treatment groups, day 5 RT-PCR, and day 7 RT-PCR, none of which were statistically significant. What reached statistical significance is a study by Bukhari, again looking at viral clearance on days 3, 7, and 14. And as you can see, as early as 72 hours, 17 out of 41 already had viral clearance in the ivermectin group compared to no ivermectin. On day 7, an additional 20 got viral clearance compared to 18. And on day 14, an additional 4 got clearance, and 25 got viral clearance in the no ivermectin group. But at the end of day 14, everyone had viral clearance. But this was reported as statistically significant. Still on viral clearance, a study by Pot Jr. Looked at the proportion of patients who would have 2 negative SARS-CoV-2 RT-PCRs within 7 days. Among the no ivermectin group, 66% already had 2 negative RT-PCRs within 7 days. That's 66.7%. That was even better than the ivermectin 100 milligrams or the ivermectin 400 milligrams. I don't know why ivermectin at 200 should perform better than the 400 or the 100. But still, there was still no statistical significance. So that ends the outcome for viral clearance. Now, when they looked at resolution of symptoms, um, the Chakar study looked at how many remained symptomatic on day 7. In the ivermectin group, 36% remained symptomatic on day 7 versus the no ivermectin, which was 40%, but still not reaching statistical significance. The one that had really unbelievably good results was a study by El Gazar, um, who reported death or progression. And in the ivermectin group, only 3.5 or 6 out of 200 had death or progression versus hydrochloroquine, 76 out of 200, or 38%. But this study also had the most issues affecting study quality. First of all, the comparison was hydroxychloroquine. And take note that if you use the wrong comparison group, you can make any medication look good by making the comparison a bad comparison. There was a randomization, but there was no concealment. This was not blinded. The baseline characteristics were never reported. There was no intention to treat, and there was no basis for the sample size. So unfortunately, this also had the worst study quality. Okay, and that about ends what I have to say about the studies. Studies look at virologic clearance with conflicting results. One study with clinical outcomes was of very poor study quality, and the comparison group was hydroxychloroquine. And none of the studies with good clinical outcomes showed clinical or statistical significant findings. And I tried my best not to look at the literature, not to look at what the agency said about ivermectin until this morning. So I just decided to add 2 more slides. And this came from the US FDA in their website, which states why you should not use ivermectin to treat or prevent COVID-19. So we don't really need to dwell on that. That's what this whole webinar is about. And another from the National Institutes of Health, which states explicitly that there is insufficient data for COVID-19 treatment to recommend either for or against the use of ivermectin for treatment of COVID-19. Results from adequately powered, well-designed, and well-conducted clinical trials are needed to provide more specific evidence-based guidelines on the role of ivermectin in the treatment of COVID-19. And I agree with this statement. So thank you very much for your attention. I believe I ended within the time that was allotted to me.
Thank you very much, Dr. Mantaling. Excellent presentation and very clear. Essentially, just to very quickly sum it up, after surveying you might say the number of studies that have been made, 218, you eventually ended up looking at 11 studies. And these 11 studies showed that there was no evidence in your assessment for the efficacy of ivermectin. Okay, so let's move then to Dr. Joy Fontanilla. Joy, you have the floor.
Good morning, everybody. Can you hear me, po? And can you see the slides?
Yes, Joy.
Okay, thank you, po. Thank you very much to PAASE for the invitation to speak. Actually, you know, this Dr. Concepcion, I was very, very reluctant to go on air to talk about this. But somebody forwarded to you the single post I had calling for sobriety regarding this issue. But anyway, I am talking as a patient advocate, as a physician looking at patients with COVID-19, and as part of the academe teaching pharmacology in the College of Medicine. So let me tell you about my ivermectin journey. Can something used for combating parasites be actually used to treat COVID? And I'm sure a lot of you have seen the video of this guy, Dr. Pierre Corey, a member of the Frontline COVID-19 Critical Care Alliance at a Senate hearing. And he was very, very passionate about, telling them, asking them to please look at the data they have on COVID-19 because it's such a good miracle drug that can potentially cure COVID-19. And actually, he was very moved by his speech. But as Dr. Mantaring already showed you, the people who are the policymakers, those who are recommending these treatment guidelines, a lot of them have said exactly what the NIH in the US have said, that there are insufficient data for the COVID-19 treatment guidelines panel to recommend either for or against the use of ivermectin for the treatment of COVID-19. And results from adequately powered, well-designed, and well-conducted clinical trials are needed to provide more specific evidence-based guidance on the role of ivermectin in the treatment of COVID-19. So this particular panel recommendation is generally neutral for recommending COVID-19 treatment with ivermectin. So if you look at the FDAs or the regulatory bodies in other countries, so this is from Europe, the European Medicines Agency also advises against the use of ivermectin for the prevention of treatment of COVID-19 outside of randomized clinical trials. Because ivermectin has not been authorized for use in COVID-19 in Europe and has not received any application for its use. And although it is generally well tolerated, that the dose is authorized for its indications, for parasites, side effects could increase with the much higher doses that we need to obtain concentrations of the drug in the lungs, which is affected by COVID-19. Right, so you need higher concentrations in the lungs to be able to be effective against the virus. So toxicity with ivermectin, when it's used, is at higher than approved doses, therefore cannot be excluded. So let's look at other statements that have come out. So surely the drug maker, the manufacturer, who stands to profit from this pandemic and the use of ivermectin, what do they actually say? They say that there's no scientific basis for a potential therapeutic effect against COVID-19 from clinical studies. There's no meaningful evidence for clinical activity or clinical efficacy in patients with COVID-19 disease. And there's a concern because there's a lack of safety data in the majority of the studies. So even the drug maker doesn't recommend it. Even the drug maker that stands to profit from this doesn't recommend ivermectin. Now, what do our local authorities have to say? So the DOH and the FDA have said their piece, and I would look at this statement because it was made also conjointly with the PISMID, or the Philippine Society for Microbiology and Infectious Diseases, all right, and the Philippine College of Chest Physicians. And the Philippine College of Physicians, our president is an infectious disease expert, and he's very, very prominent, Dr. Mario Panaliga. So I would believe what these regulatory bodies, these specialty societies would have, whatever they say, would have to say for or against ivermectin. And they looked at all these clinical trials, and they picked out the 6 good quality randomized control trials regarding ivermectin. And they really found that it does not reduce death rates. It is not associated with definite benefit in clinically important outcomes like clinical improvements or clinical deterioration, nor the need for mechanical ventilation or being put on a respirator. It does not significantly reduce the duration of hospitalization and the time to resolution of symptoms. You're going to stay the same number of days in the hospital. Does not affect the rate of hospital discharge. So basically, based on the current evidence, they say from randomized controlled trials, we do not recommend the use of ivermectin for the treatment of COVID-19. It's not been proven to significantly reduce mortality or improve other clinical outcomes. And this recommendation will be updated as more evidence is generated from ongoing clinical trials. Now, as a physician, all of us have taken that oath to first do no harm. So let's say the efficacy is iffy. What about the safety? I mean, if it is that effective, if it really is that miracle drug that can cure COVID-19, is it safe? Because there's some people are saying, let's give it out to the population already. Let's not wait for clinical trials. Let's just give it out. Okay, so if it's safe, why prevent it from being given out? All right, and so I looked through the literature and I looked for the safety studies on this. And this is one of the studies I found. So these experts say that ivermectin as a potential COVID-19 treatment from the pharmacokinetic point of view, the antiviral levels are not likely attainable with known dosing regimens. We have to remember that for the indications of this drug, which is for parasites, contrabulate, usually it's given as a single dose, right? And usually the dose is 150 to 200 micrograms per kilogram once a year in places where it's endemic, where they have to keep giving the drug yearly or twice a year because the parasite is there in their area. So in ivermectin programs, mass ivermectin programs in various countries in the world, this is the usual dose. But the COVID dose, the anti-COVID dose that the FLCC, the group of Dr. Corey recommends, is 300 micrograms per kilogram per day for 5 days. So it's not double the dose, it's not triple the dose, it's not even quadruple the dose, it's 5 times the usual dose given for the other indications for this drug. And basically, this study shows in the case of ivermectin, the potential for repurposing plausibility, if any, is at present not very likely because the antiviral concentrations would be attainable only after a massive overdose. And what happens when you overdose on this drug? And if you just search even just briefly, because I've been invited for this talk just 5 days ago, and just very briefly just looking, it's not hard to find toxicity with the drug. All right, so people who have misused it or abused it because they're so scared of having COVID ended up in the ICU. And human overdoses can be associated with vomiting, tachycardia or a fast heart rate, abnormalities in their EKGs, significant blood pressure fluctuations, effects on their central nervous system from drowsiness, disorders in coordination, in their balance, in their speech, and even vision disturbances. But just because they were foolish, people were taking it at toxic doses. So let's look at the safety profile in those who are being given it, in the massive ivermectin anti-parasite doses, okay, in the single doses, in the yearly doses. What happens and what's happened to those people? And it's been found in various countries that serious neurological adverse effects can happen. And in Africa and other countries where it's given widely, there have been serious adverse effects that were reported. And what's striking for me is this one. It was published in the New England Journal of Medicine ivermectin toxicity in a 13-year-old boy who was given just a single dose, one dose of the drug because he had scabies, or they were trying to prevent scabies. Okay, and after that one single dose, the child ended up in a coma in the ICU, but did, thank God, recover a couple of days later. And they found that it's because he has this genetic mutation that can have that ivermectin, accumulate in his brain. All right. How many people in our population will have that? It's probably rare, yes. But, if you tell people it's safe, let's give it out like candy, tell that to the mother of that 13-year-old boy. But serious adverse effects with ivermectin can be coma, can be paralysis, speech disabilities, and motor deficits, right? Because the mechanism of action of this drug for parasites is it paralyzes the parasite. Unfortunately, if you're going to give it in those high doses, you can potentially paralyze the person too. I'm a fan of the vegetarian diet, but I'm not a fan of turning people into vegetables. And other potential harms with ivermectin, as you know, if you give somebody an antimicrobial or antibiotic, it can modify their gut bacteria. And when you do that, you potentially change their metabolism and change their immunity. And this potentially can hinder immunity to COVID and other viral diseases. It can even reduce the ability to mount an effective response to the vaccine, so that when you get vaccinated, it might not be as effective. And also there's a question, when you give somebody any antibiotic or antiviral, you can induce resistance. So let's look at the probe, okay, the panels that have recommended for ivermectin. And this is the BIRD panel. BIRD stands for British Ivermectin Recommendation Development. And basically, they recommend ivermectin for the prevention and treatment of COVID-19 to reduce morbidity and mortality associated with COVID-19 and to prevent them among those at high risk. Okay, so this is taken from the BIRD panel paper. So what did they find? So basically, I just picked out those that showed favorable results for the use of ivermectin. But even by their own admission, by the admission of the BIRD panel, the evidence is low to moderate. The evidence is low all throughout. I haven't seen a single paper that says it's based on high quality evidence. If you're looking at the evidence for preventing COVID-19 infection, let's take it prophylactically to prevent getting COVID-19. Again, the evidence is low for the use of ivermectin. So what do I think about the BIRD panel? Basically, I think it flew over the cuckoo's nest. And if you look at the FLCCC paper on the use of ivermectin, they've submitted it to a lot of papers, journals, and they've actually published it online as a preprint, right? And unfortunately, the website for the journal that accepted the paper initially and put it on the website have retracted it and removed it completely. And they say that they take no position on the efficacy of ivermectin as a treatment of patients with COVID-19. However, we do take a very firm stance against unbalanced or unsupported scientific conclusions. So how about those countries where ivermectin is widely prescribed, or even, they can even purchase it over the counter? Some of these countries, they have it at every drugstore in their corner. Now, Brazil is among those countries where you can easily access ivermectin because the government, widely promotes it. right? And what do we see in Brazil, right? In Brazil, right now, it ranks second in COVID cases and deaths worldwide, despite the fact that you can have ivermectin. 8 out of 10 people in Brazil that they've asked, to join clinical trials have been already found to be taking ivermectin, and still it has not saved lives in that country. And as I always say to my patients who stop their insulin and stop their medications for diabetes, because they want to save money or whatever, for whatever reason, the most expensive medicine is the one that doesn't work. And haven't we learned our lesson already? At the start of the pandemic, we are all so excited about hydroxychloroquine. It was granted emergency use authorization. However, we've seen that it's already been removed from the treatment protocols for COVID-19. Right? Hydroxychloroquine has failed to help COVID patients in a lot of the truly good quality studies. And in a rush to publish in this pandemic state, a lot of papers will be out there. A lot of papers will be published on websites even before they're peer reviewed. They'll be published in whatever journal there is. People are out to get their 2 cents worth in this pandemic. But we've seen that does have its drawbacks. In fact, 2 very elite journals that we all really put our trust in, the Lancet and the New England Journal of Medicine, have had to retract the papers because they were rushed to publish, and it was actually found that the integrity of the data was very much lacking. So if I look at the pros and cons for prescribing ivermectin at this time, right? So the pros, it's recommended by some experts who are very, very passionate about it. It's relatively cheap or inexpensive, and it's already approved for other diseases like parasites. Unfortunately, majority of the data shows it's still insufficient. There's still insufficient evidence to show it is effective. It's not recommended by most experts and most regulatory bodies. And there is potential for serious harm, particularly paralysis, coma, and neurological adverse effects. There is, at this point, no available FDA-approved preparation in our country for human use. And there is that risk of prosecution for the prescriber. The PMA issued a circular about this, the DOH also. And the optimal dose, the treatment duration and combination is unknown. And if you want to use it as an antiviral, you're going to use 5 times the usual dose, right? Which could go into toxicity. And hydroxychloroquine, we've already learned from it, from experience, that it doesn't work. What if this turns out to be another hydroxychloroquine fiasco? So I submit to you, this is a thumbs down for me for ivermectin. So generally, please, I ask my colleagues, let's not sensationalize the data. Let's not call this a miracle drug. Let's not call for it to be widely distributed and given out like candy. Let's not get distracted from what is really important. No, we're all in this together. So let's fight COVID-19 and not each other. Thank you very much for your attention.
Thank you very much, Dr. Fontanilla. Essentially, just to quickly wrap up what you said, you went through the efficacy, which you said there was no evidence, the safety, and it indicated some of the toxicology effects of ivermectin, and then talked about finally the pros and cons. And in your view, it's not to be used. Thank you. So let's proceed to our third speaker, Dr. Benigno Agbayani. Iggy, you have the floor.
Hi. Good morning to everyone. Thank you for inviting me here at the PAASE, Philippine American, at least nauna Philippines, Academy of Scientists. That means the engineers are not scientists? No, just kidding. Okay, anyway, uh, can I share my slides?
Yes, you may. Iggy, you may share yours.
Okay,
Please.
wait lang ah. Okay, can you see it?
Yes. Could you full screen it? Thank you.
Thank you. This is my presentation for the Philippine American Academy of Scientists and Engineers, I'm sorry. I belong to the group called Concerned Doctors and Citizens of the Philippines, and it's ivermectin against COVID-19. So I think this has been a bit of a controversial topic because one of the first one that came out is this letter from the FDA. It's an official advisory and advises against the public from purchasing and use of ivermectin veterinary products against COVID-19. But what's curious about this letter is that we don't have any case of anyone reported or going to the ICU like in the United States for using ivermectin. So I think it's a little bit harsh already for the US to have given the warning for 2 ICU cases that got better. And then for the Philippines to do the same. I mean, it does take time to make these things. So why would you ever bother to say that it's for veterinary products against COVID-19 when I think the problem is that they simply took a veterinary product, but not in the Philippines. And then there was this other letter from the FDA again, a few days after, warning you from not buying an unregistered ivermectin. And they even showed a picture. So quite specific. I'm not sure that is often done, but that ivermectin doesn't look to be a dangerous product or an illegal drug. So I think they were in particular looking for this particular product, which is made by Dr. Alan Landrito, has become quite known in the past few weeks. And I think the FDA helped Dr. Landrito become popular as well, or notorious. Then came the statement on the use of ivermectin as treatment for COVID-19. And as you can see, there are a couple of logos up there, PMA, the FDA, and I'm pretty sure a lot of other incorporated private societies are up there. And they have cited some studies. There's a comment that they selected the studies for whatever reason, and they call it cherry picking. I'm not saying that's true, but then again, you should have explained that when you choose only 6 studies. And I think there's another one here. I couldn't find the actual letter, but doctors prescribing ivermectin for COVID-19 cure risk losing their license. I find that a little curious because when I prescribe, I usually prescribe generic, and I do not write there to please buy the unregistered brand. So why would you ever think that a doctor would prescribe unregistered brand of ivermectin? All I do is do my job as a physician to help my patient find an ivermectin brand, no brand rather, a generic brand to use. Never would I consider, please buy the unregistered brand.
Oh gosh.
So that's a little silly. And I think yesterday was a culmination of all these things. The Philippine Congress.
Dapat tapos na si Benny niyan. Okay, thanks.
Sir, naririnig po kayo. Si Iggy po ako, Iggy. Si Benny po ang tatay ko. Anyway, Dr. Pierre Corey of FLCC, as already mentioned, had a very good presentation. I agree that he is very passionate, and but he is well read. He even showed these graphs of from different countries and how it affected Peru. And if you really want to watch the whole presentation, it's 5 minutes. Go to YouTube and you can watch their excellent presentation. Not keeping away studies that you should that he thinks you shouldn't see. He really shows almost every study. And this is his comment in the chat box. Someone said this to me, and it's a little really emotional and passionate. I'm outraged at the DOH secretary. Well, again, he's an American. I think suppose he can say anything to the DOH secretary, which I probably would never do. He refers to conclusions of 6 trials only. There are 24 retrospective randomized controlled trials, which the results are easily available, and many observational trials. I do not protest the person who read the statement, but the author is criminally negligent. Very strong words. And the other comment you made was, thank you for your support. I'm repeatedly shocked as to how the use of ivermectin is debated with so much randomized controlled trial data. The enemies of ivermectin are driven by many financial incentives, are guilty of crime against humanity. Probably not all, but it is a very possible thing. No? Okay. And again, one of the proponents, Congressman, who talked about it, you can also view it on the same YouTube presentation, is our good Congressman, uh, uh, and he had a passionate and but very intelligent presentation there as well. But he is very much supporting the use of ivermectin because our country needs it right now, and people are dying, and that's a big issue for Congressman Defensor. Sorry about that. So as you heard, really very passionate. Now, these are my main points of why I really want to give our doctors the ability at least to use ivermectin as they deem if it's necessary or not. So I agree. One of the ethics that we doctors do is first do no harm. But if you think about it, number one, there is a void. When I say that, we don't have uh, prophylactic available. If people think that the vaccine is a prophylactic, well, it is still not yet available to even a significant number of Filipinos. As I understand, maybe less than 200,000 have been given the vaccine, but I do support its use. Second, we have an emergency. That's why we have this emergency use authorization, because we have a pandemic. It is killing people every day. It is overwhelming our hospitals. It is also causing huge collateral damage, not just to the economy, to our children, to business, to the mental health. So it certainly is an emergency. So we must do our best to do something as much as we can without, of course, causing any otherwise harmful thing. Now, next is safety. So the thing about ivermectin is it is a repurposed drug. So it is actually in the essential drug list of the Philippines. So even the FDA is actually required to have this wonder drug on our shelves of our drugstores or pharmacies. So you come to wonder why it's not available. You know? So it's been monitored by the WHO for 25 years, and they monitor adverse events and deaths. And you won't believe this, out of 25 years and more than 3.5 billion doses given in those 25 years, they only reported something like less than 7,000 adverse reactions. Not, it cannot be said even of vaccines or other things that are already being used for this COVID-19. The other one is deaths. In those 25 years, 16 deaths had been linked to ivermectin, but I saw the study itself, and they cited 15 deaths in one big study of in a nursing home where they gave ivermectin. Again, it is not yet fully was not fully disclosed if it was directly the cause of those deaths, but it is certainly associated. But again, 16 deaths for 25 years. I'm sure you've heard of the deaths from other things of these diseases that's not even 1 year. That's 10 times more than those 16 deaths. So certainly I have to say that this is a very safe drug. Maybe I can answer the presentation of Dr. Castillo, who is a good friend of mine, Barkada pa nga, and her husband is my very best friend, Dr. Dino Fontanilla. So I think one of the things we should mention there, that there are studies which show that you can even take 10 times the dose recommended by the NIH, even 4 times the dose that being recommended by the FLCC on a daily basis. You will still have no side effect. And there are studies to prove that. Okay, so the next problem is efficacy. So efficacy is still debatable, but I could cite to you 5 meta-analyses later. No? Now, the fifth problem that no one is talking about is actually the big elephant that no one is talking about. COVID-19 is a crisis. However, it is also an opportunity. And when I say opportunity, money is being made. There will be vested or conflicts of interest. There will be countries that will fall in a deep hole where it can no longer change its mind because if it had spent billions of pesos, how would you admit to your country that you've spent that without actually improving the pandemic? So it's like a deep hole. It's like never admitting that you're wrong. And of course, there's big pharma money. Just to describe to you how big pharma money affects the way countries would recommend a certain drug. Did you know that most pharma companies would spend millions of dollars for lobbying at the White House to promote or push their drugs? It is not illegal, but I tell you, there is money going around with big pharma. And I think this is already common knowledge to most of us here. This is like is a site or Ivermeta. You can check it out, which sort of like puts in all the information that comes in about studies. And you can see here that there are 40 studies to date showing positive effects, and 23 are statistically significant. And there are 25 randomized control. I checked this morning, so this is the most updated one. And don't mind, this is, even for me, this is quite difficult to understand. But you can see that here for early treatment, this is of course just, I call them signals because I agree with our first 2 speakers. They are not necessarily hard or ironclad evidence, but look at the range. It's 56 to 90% for early treatment. For late treatment, it's a little lower. But look at that. Lots of patients already when you accumulate it. For prophylaxis, it's a little high. And the lowest you can get is 77% out of 12 studies. And there are studies on mortality, improvement of 76%. Well, if you have a vaccine that can help only 50% and we allow it, I think that's an issue for me. And this one are all the 21 peer-reviewed trials. So this is just sort of all the peer-reviewed trials already. So that means they're published. Some of them were mentioned by our esteemed speakers earlier. So you can see how these are graphs showing sort of where, if it's here, it's neutral. So there's some positive signals of positivity, both early, late, and even for prophylaxis. And those are based on peer-reviewed trials, 21 of them. And I would like to note that there are now 4 meta-analysis. One has been accepted. I think Dr. Fontanilla mentioned that CORIS was declined, but it has recently been accepted for publishing already. That was just 4 days ago. So I think she was not able to know that yet. So, but it's now published because there's another expert in the Philippines. He said that meta-analysis that has not been published don't count. I have to disagree with that. Okay. So the conclusion is ivermectin is an effective treatment for COVID-19. As expected for an effective treatment, early treatment is more successful with an estimated reduction of 79%. So the recommendation, I'm not in the business of recommendation. I really look at these things as my own assessment. And then some people ask me is, why are you supporting ivermectin? Because that's how I perceive the data. I do not want the NIH, I don't want the DOH to please accept my perception of the data. I suppose that that's my right as a physician. I do have a relationship with my patient. It's a partnership. I show them the studies that I read, and the patient may or may not want to take the medication that I offer them. So there may be probably questions later, but I'd like to say it again that I'm not a researcher, unlike my father. I would perhaps belong to the World Association of Independent Armchair Researchers, and I'm the president of the Concerned Doctors and Citizens of the Philippines. Thank you.
Thank you very much, Iggy, Mr. Bayani.
Thank you.
Yes, I knew your father.
You called me Benny po. Iggy po ako, Iggy.
Yes. Well,
Naalala ko
anyway,
tuloy.
just very 3 points just to summarize what you said. Essentially, you said that there is evidence for safety, and you cited that out of the billions of uses of ivermectin, very, very few adverse events have been reported to WHO, and also very few deaths. You cited the efficacy of ivermectin based on the meta-analysis of the various studies that you showed. And finally, you cited political interests and business interests behind the suppression of ivermectin's use. So thank you very much. And we'll go and move to our next speaker, Dr. Benji Ko. Benji, you have the floor.
Hi, good morning, everyone. Let's see if I can try to share my screen. Okay. I actually did not want to make a presentation, but I made one in the interest of, can everybody see it?
Yes, Benji.
Yeah,
fine.
all right, okay. And it's actually very short. I have to leave almost immediately. But let me talk about regulatory matters that matter. And I think one of the bigger issues that surround this are on the regulatory matters that matter. No? Number one, my disclosure is that I am neither for or against a repurposed product. All we want at the end of the day is the same thing, that patients get better. So there are those that go into complementary and alternative medicine. There are those that prefer repurposed medicines. My mom is 83, and for other medications that she will need for treatment of her cancer, she does acupuncture and all of the rest. So I am not one who does not believe in any drug that has or sees potential. But having said that, let me start off my talk with what regulations are, because I think everything hinges around the regulatory issue. So there are only 6 things I want to say. The first is Republic Act 9711. This is a law. No? So I was in the congressional hearing yesterday. Whatever you talk about and whatever the government officials say, they need to rescind this law before you can allow something that is off tangent from the law. Because Republic Act 9711 puts forth the role of the Food and Drug Administration as the gatekeeper for every product that comes into the market, whether it is food, drug, it is cosmetic, or it is a medical device. And they actually make sure that the quality, the safety, and the efficacy of all of the products are made in a manner wherein are done in a manner wherein they have gone through assessment properly. And I say that because with conviction, because I used to be the director for the Center for Drug of the Food and Drug Administration. So I know what I'm doing and I know what I'm saying. There are different types of licenses to operate. No? Whether you're a trader, distributor, manufacturer, compounding facility, a clinical research organization, laboratory, a bioequivalence center. So lahat ng papel, lahat ng mga iba't ibang role, ay hindi naman LTO lang yan to operate. Operate as what? That's the important question that you must answer. And let me tell you the story of Republic Act 9711. Now, this was a law that was enacted. It's an act strengthening and rationalizing the regulatory capacity of the Bureau of Food and Drug, and later on it was called the Food and Drug Administration. And there are three objectives of that law. One, to enhance and strengthen the administrative and technical capacity. Two, to ensure the FDA's monitoring and regulatory coverage over establishments and products under its jurisdiction. And three is to provide coherence in the FDA's regulatory system. And that's the reason why the purchase, selling of drugs that are not registered by the Food and Drug Administration are not allowed by law. The other objectives I tackle very quickly is that, this is a different story from hydroxychloroquine. Hydroxychloroquine did not receive the same flack as ivermectin because hydroxychloroquine was available already in the market. And while its major indication was for the use in patients with rheumatoid arthritis, hydroxychloroquine's availability allowed doctors to prescribe it for a different purpose. That's not the same story with ivermectin. Ivermectin, on the other hand, has no human preparation available locally. If you look at the last national formulary in 2008, ivermectin was part of the national formulary. It is not there anymore in the 2018 edition. When you look at the pharmacology and drug manufacturing, there is a need to consider the final preparation. You cannot just put raw materials and then just compound it, put it inside a capsule and take it. All of the drugs that are made are actually made with excipients. They have extenders. You look at the pharmacology. In short, yung tabletas na iniinom nyo, yung capsule na iniinom natin, hindi lang yung raw material yung nandun. May mga iba't ibang samut-sari na mga dinadagdag para na-absorb in the right place. Because that's basically what a drug is supposed to do. It needs to get absorbed in the right area. Absorbed, distributed, metabolized, and eliminated by the body. So pag na-absorb siya, pumasok siya sa stomach where there is a very high pH and there is no other binder or excipient or extender that is added to that particular product. Where will it go? It just gets destroyed there. And so you're not taking any other drug for that matter. So there is no absorption, there is no distribution, there is no metabolism, and there's no elimination. Why? Because everything just got destroyed in the stomach, which has a very high pH. That's the reason why our stomach is very acidic, because it tends to destroy everything that is taken when it reaches in that area. And the reason why drugs are made in a way wherein they escape that pH and therefore they go into the smaller intestines and can get absorbed and found in blood later on is one of the reasons why it is important that the final component is one that is manufactured and compounded properly. So I really have no objections on selling an ivermectin that is legit. Okay, so we're talking about the legitimacy of the manufacturing site. We are talking about the legitimacy of a drug. And therefore, we must make sure that whatever is available in the market is one that has been manufactured properly. You go to the issue of also of companies who do not put COVID-19 or other viral infections in their indications. Kasi even the manufacturer, the innovator, and other companies have not placed this in their label. And because they have not, then it puts them in a spot wherein who becomes liable. The Food and Drug Administration has no business in adding an indication to it. Hindi yan papel ng FDA na, o sige, dagdag natin yung indication for COVID-19 because the FDA is just a regulatory agency. It reviews all the documents of other pharmaceutical companies who apply, and that application must show evidence that the indication that they put there is supported by facts and evidence. And of course, the issue on moving forward. So what do we do now? There's a group that calls for the use, and I want to see whether it is useful or not because I'd really like to try it. The question is, I want to get one that is a legitimate drug from a company that has good manufacturing practice. And how do we do that? We either go through a compassionate special permit where you just import it from a company that already manufactures it for use in your patients, or we do a clinical trial for it and then you import several drugs, and I think this is the way to go. And of course, the off-label use for some patients who are able to access it, you must make sure that they sign a waiver with a written informed consent that you have explained everything and that they understand everything with what you are prescribing, that it is not approved for this particular purpose, but in your opinion, you feel that it might see a purpose for this. Let me show you the geographical distribution of chemotherapy for the status of preventive chemotherapy for onchocerciasis. No? This is the major indication for ivermectin, which was discovered as IVERMECTIN initially. You will see that it is most predominant in areas where there is already a CPR for it. So, katulad ng Brazil, ng Peru, ng all of these areas, no? It's already marketed for it. Why? Because they use it for onchocerciasis. The mere fact that we don't see a lot of onchocerca bulbulus in the country, it's one of the reasons why the company, or any company for that matter, does not bring the drug in selling it in the country for that particular indication, and also for the indication of strongyloidiasis, because you are right to some extent that it is business. Business for selling ivermectin for the indication that it is approved in. And the story of Peru is a sad one. While, you know, we say that Peru had success in the treatment with ivermectin, this is where they are today. So let's keep the facts real, and let's make sure that we follow regulatory science, because while we aim for one purpose and we want to find the cure and to heal, we remember also one thing, and that important thing is primum nocere as physicians, to first do no harm. And patients must understand that as well. While we are passionate at looking for a treatment, particularly in this pandemic, which has driven us against the wall, and in our second surge, more mental health issues, we need to remember that we need to keep an open mind on the pros and cons instead of our emotions. COVID is our common enemy. Let's use science and regulations when we decide what is best for patients. After all, the most expensive drug is the one that does not work. Thank you.
Thank you very much, Dr. Benji. I know that you have to leave very soon, so just to appreciate your coming. And just to summarize that, essentially, Dr. Ko has emphasized the laws that we have, particularly with regards to FDA, and that FDA is the gatekeeper, and that sets certain rules about use of the drugs. And that in the use of the drugs, FDA also checks the final product that is actually put in the market. If any of these products are used off-label, then certain mechanisms have to be used for that type of off-label use. So thank you very much, Benji. And I now give the floor to our fifth speaker, Dr. Vic Ilag. Vic, you have the floor.
Yep, thank you.
Yes, Manolet, we can take a look at that box.
Yeah, why don't we just look at the chat box, Giselle?
Yes. All right.
We can probably process some of the comments and the questions that are there already.
Okay.
Okay, so well, you know, one of the things that actually came out, and let's go to the pros and cons, you know, is that in the area of efficacy, Dr. Mantari, Jojo, actually presented his analysis, where he looked at different studies one by one. Okay, whereas Dr. Iggy, or Benigno, Iggy Agbayani, actually presented, you know, meta-analysis where studies were made and they looked at the efficacy vis-a-vis ivermectin and placebo, et cetera, et cetera. Maybe I should ask Jojo, can you make a comment on the meta-analysis that actually has been presented, evidence for the efficacy of ivermectin?
Okay, can you hear me?
Yeah, I can hear you.
Okay. Actually, I never saw the meta-analysis that was presented by Dr. Agbayani, but I did see a meta-analysis. I neglected to present, so I hid a few slides. I neglected to present it because it didn't really add to what I already said. But maybe for the interest of the audience, I'll try to explain first what is a meta-analysis. Oops, this is not the screen that I wanted to share. And I'll go over one meta-analysis, the one that is, I hate to say the term, it's a Cochrane analysis. So, and the reason why I want to emphasize that it's a Cochrane, because there is a group, no, that advocates for using meta-analysis for policy decisions. And this is the Cochrane collaboration. But let's not get into the details of that. But let me just show you the slides that I neglected to show. I hope you can see my screen.
Yes.
So, well, first of all, what a meta-analysis is an analysis of trials of the same nature, no? Like the trials which are alike. You will notice that I described each study, mentioning what types of patients were there, what were the interventions and the doses, what were the comparison interventions, and what were the outcomes. Because if you come across studies with the same population, exposure, comparison, and outcome, and the same methods, theoretically, you can combine the results of these studies and you can do an analysis of the pooled results to come up with conclusions. And there's a systematic review which was published actually by the Cochrane collaboration. By the Cochrane collaboration is a collaboration of scientists that use the same methods for the synthesis of data. And they're very strict, no, as to the methodology and the quality of the analysis. And so this is a Cochrane review by Biswa, Mohan, Padhi, etc. Unfortunately, I did not see how many studies they started with. But what's fortunate is most of the studies, or practically all of the studies that they included in this meta-analysis, I already presented as individual results. Now, one of the methodologies for the meta-analysis is first to look at the risk of bias for each of these studies. So I'll very briefly just walk you through this risk of bias table. So the Chowdhury study, the Goryal and Rajiter. So these were all of which were mentioned in my analysis. And they looked at biases from confounding, biases in selection, biases in classification. And let's just focus on the last column. Overall, all of the studies that were included in this meta-analysis had a critical risk of bias. So that's the first. But they still went on to analyze the results. Unfortunately, for one study, it was not combinable. So you will see that the Chowdhury study had a lot of zeros in their event rates for all-cause mortality, and they didn't include that in the analysis. So in essence, there are two outcomes here: all-cause mortality, which I talked about, and clinical improvement, which I also talked about. And in their analysis of the results, they showed that it actually favored ivermectin. But let me just say that the confidence intervals were very wide. So these are the results of the Chowdhury study: 0 events out of 60 for the ivermectin group compared to 0 out of 56. And they're looking, because they're looking at mortality, and the event rates for mortality were actually very low, except for the Rajiter study, which was the study which was of very low quality. So 26 out of 249 versus 29 out of 234. And this became statistically significant. Although, if you look at the upper end of the confidence interval, it practically touches 1, which, and a relative risk or an odds ratio of 1 means that the odds of the outcome among those given ivermectin and no ivermectin are practically the same. For clinical improvement, it's the same. No? It's 1.09 to 3. It also favors ivermectin. But let me just show you the grade table. Grade is another group, and grade is an acronym that stands for Grading of Recommendations, Assessment, Development, and Evaluation. And for all of these, they showed that the risk of bias was high, and therefore the quality of the evidence is very low. So for both all-cause mortality and clinical improvement, although they seem to favor ivermectin, the quality of the evidence is low. So I think that's all I have to say. To me, the bottom line is, when we did our search, we saw that there were maybe about 80 ongoing clinical trials. And I suspect that in the next few months, the results of these trials will be coming out. So let's not rush judgment and say immediately today that there's no evidence. In my opinion, we can afford to wait for the results of these trials before we pass judgment on the use of ivermectin. So that's it. Let me stop share again.
Thank you very much, Jojo. That's very useful. I think it's very important for people to understand, what they're looking at in terms of the data and what's actually inside the data and the selection of studies that's important in dealing with these issues. I see now the slides of Vic Ilag on the screen. Vic, are you ready to present?
Sorry about that. Pasensya na.
Oh, good. Okay, Vic.
I'm online, so I think it's going to be controlled by Giselle.
That's right, Vic. I will control the slides.
Yeah, so next slide. So I won't cover the basics of the virus. So we go to this next slide, please. So that's ivermectin. So without any further introduction, so what I would like to show here, oh, it looks like a dark spot. Essentially, that was the molecular structure of ivermectin, essentially composed of two molecules. It's of the ivermectin, was originally isolated as ivermectin, which has the most activity against worms. But the final formulation is actually composed of two molecules, 80% of the B1A isoform and the other one's the B1B, and the only difference is one carbon atom. So the mechanism of action, the way this works, so it essentially stabilizes the ion channels. So ion channels are proteins on the surface of worms, and it's scattered all over the worms. So what it does is ivermectin inserts itself into the ion channel and keeps the ion channel open. So what happens then is there's a hyperpolarization to literally the worm has a lot of holes. So literally the worm explodes, and that's how it kills the worm. And one of the toxicities about it is a person has too much worms in the body. If you give them ivermectin, it will explode and cause toxicity to the patient. So other toxicities, I think, was mentioned by Dr. Joy, was potential neurotoxicity. However, because this molecule is relatively big, it does not cross the blood-brain barrier. So even though we have ion channels which could be targeted by this drug, the drug is not really able to penetrate the blood-brain barrier. Furthermore, we have a protein called a P-glycoprotein, and that functions as something which does not allow this protein to enter the brain where most of these ion channels are. However, there are mutations as indicated, which could render this useless, which would then lead to potential toxicity. But as Dr. Iggy pointed out, based on actual pharmacovigilance data, there hasn't been a lot of deaths. As a matter of fact, I think ivermectin has been considered one of the most safest drugs, actually 10 times even safer than aspirin or paracetamol. So next slide, please. So ivermectin is an antiviral. So going back to history, so this was discovered actually more than 10 years ago as an antiviral by Kylie Wagstaff at Monash University here in Melbourne. And the original idea was HIV uses a host protein, the importin, which essentially is like a bus which delivers and shuttles proteins from the cytoplasm into the nucleus. And nucleus is the central control of the cell. And that's what it does. But viruses, for some reason, have hijacked this bus. And what they do is they end up delivering themselves into the nucleus and then takes control of central command and essentially dictates how the cell should behave to the favor of the virus. So what they did was they screened for molecules which could bind to this importin. And one of the molecules they discovered was ivermectin. And what ivermectin does, it binds to a component of the importin complex and disables it. So therefore, it's almost like making a shuttle bus a flat tire so that it could not deliver the viral proteins, therefore unable for the virus to control the cell. So that's how it works. So last year, because of COVID, and they tested this against a variety of viruses such as dengue, Zika, chikungunya, and even other DNA viruses. And that seemed to work really well. So when they tested it with COVID-19, they showed 5,000-fold reduction within 48 hours. And this was at a concentration which I think Dr. Joy presented was very toxic. And I'll address that because there was issues about that, anything that has been resolved, and I could easily address that issue. So go to the next slide. Essentially, there are three stages of the SARS-CoV-2 infection. First is the binding and cell entry. And then once the virus binds and enters the cell, it then replicates and forms more viruses. And the third phase, essentially, when there's uncontrolled virus production and spreads through all over the body, it leads to inflammation and what you call more the cytokine storm. So the question then is, does ivermectin play a role apart from this blocking of importin as showed by Dr. Kylie Wagstaff? So without going to further, this is a bit complex slide, but essentially what it shows is the virus binds through receptors, TMPRC2 as well as ACE2, it's been shown that ivermectin by modeling could inhibit the binding of, could potentially bind to these targets, therefore rendering the virus inactive. So once the virus enters the cell, it actually releases its RNA or the genome to produce other proteins. And one of the proteins produced is a replicase, an enzyme which is responsible for producing more RNA molecules. At the same time, it also produces a protein, which is a protease to chop this into smaller pieces to create active proteins. And that, it seems, based on molecular modeling, also is inhibited by ivermectin. As earlier mentioned, these viral proteins could also then go into, bind to the important and go to the nucleus and take control of the cell and tell the cell to just make COVID-19 viruses. However, that could also be blocked by ivermectin. So once you have a lot of these viruses produced, it takes about 10 hours from the initial release of the nucleic acid from the virus all the way to the first virus to be produced. And then once you release a virus, this then goes outside of the cell and infect neighboring cells. Once the cell starts to get sick, it continuously produces a lot of viruses until it runs out of resources. And then once the cell, before that happens, there's a signal sent to the nucleus by a protein called NF-kappa B, which actually requires transport into the nucleus to send the signal to make more cytokines. So the cytokines, like IL-6, TNF-alpha, their role is to bring more of the immune cells to help out and repair damage or find or defeat any foreign entities such as a virus. Now, the complication, if this cytokine storm, if there are too much cytokines being produced, this leads then to a cytokine storm, and that's where there are complications. And I'll discuss that in the next slide. However, before sorry, Giselle, can I push back a first slide? So if NF-kappa B is not transported, that is inactivated. And we know ivermectin prevents the important to bring in NF-kappa B. Therefore, there won't be any cytokines produced. So if you look at from this slide, essentially ivermectin works on at least two or all of the three components required in the viral life cycle. If you go to the next slide, I think something, and I'd like to delve more into this, like crossing the Rubicon. Essentially, this is where the point where inflammation becomes so severe and actually the main reason leading to death and difficulty in breathing. So what's shown here essentially is an air sac. And what I'd like to show here is that it has been shown that people who have comorbidities usually have low levels of these EETs or SPMs, which are actually just metabolites of omega-3 fatty acids. Recent studies have been shown with the blood that omega-3 fatty acids, people who have high omega-3 fatty acids have a low tendency to have a less risk of dying. And the reason that is, it's that it has these anti-inflammatory effects. And one of the issues with having high inflammation is the immune system is not functioning well. If to the left of the screen, you'll see that there's something here as an eicosanoid storm. So that actually is the storm which precedes the cytokine storm. And one of the things you probably heard that dexamethasone works well, and that's what dexamethasone does. It shuts off this eicosanoid storm to prevent further progression to the cytokine storm. So it has been proposed that if you increase your amount of EETs or SPMs, you actually could prevent the cytokine storm and actually also stimulate B cell production. What was interesting about recent studies, if you show here to the lower left, the reference Blakely BR, it has been shown that actually ivermectin works, at least shown in mice, that it could stimulate T cells. So that if you have an antigen which is T cell dependent, you actually increase antibody production. And in this case, if we know that it seems that the T cell response is important for the immunity against COVID-19 or SARS-CoV-2 virus. And a more recent study here, which was first published this month, where ivermectin actually could convert cold tumors and synergize with immune checkpoint inhibitors. Essentially, ivermectin has the potential to also induce cell death in cancers and more importantly, leads to infiltration of T cells of cancer cells. So which suggests that actually there is a T cell component, T cell immune response where ivermectin could play a role. So that would suggest that there might be some synergies with the T cell response, which would be important for vaccination. So if you go to the next slide, Giselle, please. So this summarizes essentially that the role of ivermectin in the viral life cycle. Highlighted in red are essentially studies based on modeling. So it hasn't been shown experimentally whether they actually inhibit viral viral cycle, but it actually plays a role on inflammation and cytokines. So the others in black are essentially shown in vitro, or at least in animal models such as mice, that there is an anti-inflammatory effect. And this is consistent with observations with people apparently who take ivermectin. Have you seen that they have anecdotal evidence that it reduces inflammation for diseases such as psoriasis and others? And because NF-kappa B actually is the molecule which turns on the production of IL-6, TNF-alpha, and IL-1 beta. One of the drugs being used is the tocilizumab, and that's against IL-6 receptor. But if inflammation is induced by different cytokines, you would need 3 different antibodies to reduce that. And that's why the IL-6 receptor antagonist hasn't really performed that well, but yet it is still used for treatment. So the conclusion here is that ivermectin seems to operate on all stages of COVID-19 infection. So the last slide, essentially just shown by Dr. Iggy. This is consistent then based on the mechanism of action, could explain how ivermectin could play a role in both early treatment, late treatment, as well as prophylaxis, and that's supported from the clinical studies. Next slide, please. So ivermectin issues. I think this was covered, and I'd like to address, I think there were from the early studies from Dr. Jojo, as well Dr. Joy, citing the NIH statement as well the EMA statement. I think it's worthwhile to address, and there are links here below, the response of the FPLCC Alliance, as well as that of the BIRD Alliance, because they have point by point, and it's worth reading. And I just summarized rather than cover all of those, but I recommend reading that, is that a few of those. So one is the meta-analysis of 21 randomized clinical trials. So what meta-analysis does, even though clinical trials are often different, what it does, it combines it and analyzes it so that you could then normalize and create and come up with a statistical power whether that is possible. On the terms of the sample size in clinical trial, too small, underpowered, and some are still making this comment. One has to realize that in a clinical trial, it's not only about absolute number of patients as a sample size, but what matters is statistical power and effect size. A difference in effect, whether it could be measured, matters. So if you have an effect size is big, you do not have to have a large sample size or large number of patients. And that has been addressed also. Again, I would recommend that everybody read this particular link. Then thirdly, on the ivermectin dosage, I think this has been a bit debunked already, and I'd like to just point out, so that when the original experiments were done, the reason they were done they were done with green monkey kidney cells. And the reason they was done, first of all, that was first grown here in Melbourne, at the University of Melbourne. And that was the cell line used. So that was the one they used for it. And based on initial analysis and the modeling using different assumptions, that's where the idea that it takes about 100 times of that particular dose from that in vitro study to get that same effect. Now, fortuitously, some other doctors didn't read the memo and still used ivermectin, but they were dosing it not at 100 times, but significantly less, but similar to the dose of what's being used. And from that, they were able to get that. So that was happening on the sideline. But at the same time, Kylie Wagstaff's group at Monash repeated the experiments and then used it with human alveolar cells. So the human lung cells, which are targeted by COVID-19, which gives you the effects, the difficulty in breathing. And they showed that the IC50 is actually within the human dose range, acceptable dose range. At the same time, similar studies have been done on the modeling, because one of the problems with the earlier modeling, they were not factoring in that there was accumulation of ivermectin in the lungs. And based on that, it's pretty much within the acceptable dose level. And that's where Dr. Iggy also pointed out that you could have 10 times, it's still within the maximum tolerated dose. So in terms of dosage, there's no debate in that. And again, I would refer to this. So with regard to the NIH EMA comment, it's worthwhile to read this, and it would be, I think, moving forward, if there would be a rebuttal to the rebuttal of these particular ones. Okay, thank you very much. No, so I move to the next slide. So I'd like to hear in this slide now, it's like a shift of gears, because like a bit of viral math and multiplication, because as we debate, I think what's whether ivermectin is good or not, the virus is multiplying. And this is what we've been mentioning for months ago. So if you start with one virus, we know that this virus replicates after 10 hours, it produces about 1,000 virions per viral particle. Within 48 hours, you could, assuming only 10% of the produced virions could reinfect new cells, you'll have about 1 billion virions after 48 hours. That's within 2 days. If you only assume 1%, that would be a 10 million within 2 days. Now, the important thing to consider, though, is this virus makes an error rate of about 1 every 1 million nucleotides. So it replicates. The size of the genome of COVID-19 is about 30,000 nucleotides. So every 34th virus is roughly a mutant or a variant. So if you picture it, then within 48 hours, if you have 1 billion virions, you would have about 33 million variants. So if you still continue to 4 days, then you would have at least trillions. And this has implications then. If we do not stop this multiplication as early as possible, we are producing a lot of variants, and these has consequences. The next slide, Giselle. So I'd like to hear make a dengue comparison. We know, although dengue is a blood-borne disease, we know a blood-borne virus disease. It is transmitted by mosquitoes. And one of the reasons why we don't have a pandemic, we usually have an outbreak, is we have an action plan for it. Essentially what we do is you find the source of where these mosquitoes are, you destroy their breeding grounds and prevent it by preventing further transmission of mosquitoes. So next slide. So let's say if we do a thought experiment, this is what it would look like if we, so currently, it'd be easier if I were doing this manipulated by myself, so I could do it sequentially. But anyway, the whole take-home message here is this is the current strategy we have. So this is how transmission happens. So there's no vector, there's no mosquito. So unfortunately, there's nothing we could destroy. However, our current approach is to use mask shields, social distancing, circulation, better circulation, quarantine, and washing hands. Unfortunately, that doesn't stop the virus. We do not cut the multiplication process of the virus. So if we were to apply that to dengue, essentially we would be wearing nakakulumbu tayong lahat. And yet at the same time, the virus is continuously replicating. So I move to the next slide. Now, with terms of resistance, I mean, people say that if you take a drug, it would lead to resistance. Actually, that's not really true. What's essentially here, you start with the population, you put selective pressure, let's say an antibiotic or an antiviral, then you enrich for the particular variant which is in that particular population. And that's where you propagate resistance. That's why it's recommended you then have to kill as much as possible, as many as possible early. But the source of the variant precedes the selective pressure. So if there's no variant, no matter how much selective pressure you put, you're not going to create any selection for variation. So that's why the key, this essentially slide is referring to, which is relevant to the previous slide. If we do not control multiplication of spread of the virus, this will continue to multiply. So even if you double your mask, increase your distance, any infected person, if there's no efforts to reduce the viral load, will still continue churning lots of virus. As I pointed out, within 48 hours, you could still have 1 billion to trillions of virus, and we continue keep on shedding. So the fact that we have another outbreak now with variants is not surprising, because most of the efforts are not does not involve reducing viral load. So that's why the importance of treating early. So I think it's the second to the last slide, but there is an option. So one is povidone iodine, which is commonly used as known as betadine. So there was a randomized clinical trial done in Bangladesh. It was 606 patients, so it's pretty good size. And the control was just lukewarm water and together with povidone iodine. And the treatment was a gargle, a nasal rinse, as well as an eye drop. And what they found out is after 3 days, you could reduce it out to 89%. And after 7 days, down to 96% are RT-PCR negative. So that's the clinical outcome. They've also, a secondary outcome, they've noticed that the people who had this treatment had less need for oxygen. And one of the reasons, I think more recent, is people think that it's only nasopharyngeal, but the recent studies show that actually there's a high concentration in the oral cavity and saliva. So next slide, please. So this essentially summarizes it. So ivermectin seems to work on multiple stages of SARS-CoV-2 infection process. Like the next thing is the current strategies we have do not effectively address viral multiplication and spread. And there's a lack of immediate implementation of early effective mitigation. So I know we're discussing, and at the center of our discussion is ivermectin, but as we debate, I think it's very important that we start to take control, that we do early interventions during this pandemic, so we could further reduce any complications. Maraming salamat, and hopefully looking forward to the discussion.
Thank you very much, Vic.
Thank you.
So essentially, just to summarize, you've actually discussed the mechanisms of ivermectin in worms and also in vitro with viruses. And so essentially, you've talked about, could you mute please? You've talked about how ivermectin blocks viral replication, can actually prevent the production of cytokines, can stimulate T cells in mice, and even can induce cell death in cancer. So it seems to have a lot of mechanisms. And you also touched on a number of issues, particularly the rebuttals of the FLCCC and BIRD on some of the discussions that comments that were already made.
Yep.
So with that, I think we've completed all of our speakers. Thank you to all of our 5 speakers for their wonderful presentations. I think it's very, very clear how the pros and cons arguments have come out, no? And I already started by asking Jojo about, his comment on looking at the studies one by one and looking at it as a meta-analysis and as a group. And essentially, I think there are pros and cons to looking at meta-analysis as a group. One con there would be the inbuilt biases that each study might actually have. But a pro really is, as Vic said, there are effect sizes that probably statistically conspire towards showing whether it's effective or not. Okay, and I just say that in order to explain it to laymen. So, but I think as Jojo said, and as others are saying in the chat box, the debate doesn't seem to have ended, and there are still studies that are coming on board, and therefore we shouldn't make any rash judgments, but we should keep the door open and continue to look at the data. But before I open the floor to the group for comments and questions, I'd like to ask Joy Fontanilla on the issues of safety and also Iggy, because there's a pro and con here. Joy has mentioned the toxicological effects of ivermectin, but there is the other point that actually there's a very wide margin between the therapeutic doses and the toxic doses. And apparently this is quite wide. And WHO itself, given all of the doses of ivermectin that have been given in Africa and South America, have shown or have gotten very few comparatively reports of adverse events. So could you comment further on that? Is there really a safety issue on ivermectin given what we know so far? Joy?
She left, I think.
She left. Okay, sorry. Well, is there any toxicologist in the audience that might want to comment if Joy is not in the audience anymore or in the panel anymore? Okay, there's none. So we'll just suspend that question then. And therefore, I think the takeaway here is that it's not a closed judgment that ivermectin is actually toxic, okay? And that we should look at the clinical experience with regards to its use, particularly since practitioners are using it. So going forward then, can we open the floor, Giselle, to the comments? And could you just scroll downwards if you want, and let's pick out the comments that are important. You know, one of the comments that was made is this: why did the
Manalet, we lost you.
US NIH change its? Let me stop my video then. Why can any of the panelists comment on why the US NIH actually changed its recommendation from not recommending it to not recommending it or not recommending it? Meaning to say they were neutral. Can any of the panelists answer that? Benny? I mean, Iggy?
Yes,
Sorry.
sir. I think it's a bit puzzling when they gave the comment of not recommending it, being a safe drug anyway. So I think what they should have done, what they did now is a correction. Because when you say not recommending it, it will do more harm than it does good. Usually the recommendation is that we don't have evidence. So then they turn into that statement, which is the correct statement. Kasi hindi naman talaga zero evidence. There is some evidence. So hindi naman dapat na ginawa yun na not recommended. So it's a correction.
You know, given all of this, and I won't turn on my video because I think my bandwidth fluctuates. Can I ask the panelists now, given the pros and cons, and looking for the way forward, okay, could you comment on one? What are the ethics behind the use of ivermectin in these circumstances, given the state of the science? Given the state of the science, okay, and we know the pros and the cons, what's the ethics for using or not using it? Can I ask comments from our panelists?
I would defer to doctors.
May I answer?
Jojo, do you want to start?
Actually, as far as its use is concerned, considering that this drug is not considered an investigational new drug, it's as Dr. Ko has said, a repurposed drug, then ethically, physicians should inform their patients that this is not the indication for why the drug was manufactured, and therefore patients should consent to its use. And they can only consent to its use if they are given enough information, enough for them to make an informed decision, which is different from using it in a clinical trial model. No? In a clinical trial, of course, because the efficacy has not been proven. Of course, it also needs consent in a clinical trial situation. But right now, because for clinical practice, then I think the physicians are required to inform their patients that it is not the standard of care, and that if they do this, then they're doing this after having been given enough information to make that decision.
Thank you, Jojo, for that comment. Vic, do you have a view on this? Then Iggy.
Sure. Yeah, my name is Vic Ilag. So with regards to this, so I'm not a medical doctor, so it's way above my pay grade. But anyway, my comment, I think I'm just going back to my presentation. The issue right now we're debating whether to do this or not. The reality is the virus is multiplying. The virus multiplying, the virus mutating. Our efforts, there are no efforts I see which really reduce the viral load. And that would be my priority. I think with regards to ivermectin, I think there's potential based on the risk to benefit. From my opinion, I think the risks are low and the benefits are high.
Okay, thank you, Vic. Iggy, do you have a view?
Yes, very much. Ethically, as they said, first do no harm. I think if you take a paracetamol, I mean, you can take it over the counter. So I'm pretty much safe that it's to understand that it's no harm. So the next one is do nothing. Shall I do nothing if my patient is not even offered anything or recommended anything when they're very scared, even if it's placebo? Sometimes it has some benefit, but there is data, and it's a matter of how much understanding of like Dr. Mantaring mentioned. This is not a clinical trial. We're down onto the war zone itself. I would throw anything just to be able to say that, first of all, I did do care for my patients, and therefore try my best to look for information and inform the patient that, look, I saw 24 randomized controlled trials. There are a group of people who I also believe in their capability and they recommend it. So, and I agree that there are people who do not recommend it for very strict trials, but times have changed. This is an emergency. So I think we are ethically, personally, we are ethically bound to at least try it.
Okay, thank you, Iggy. Now, let's go to the way forward. Okay, and as FDA said, there is no ban on ivermectin, but there's really no product in the market. And the products that are there are being compounded, okay? And FDA says, unless it's registered, you shouldn't use it. So I guess the question that I want to put forward to the panelists is this. What then do you recommend FDA do? And what should those that believe ivermectin is useful, what should they do?
Yes, I may answer that.
What's the way forward then? Okay, Ben, Iggy, please begin.
Yes, Dr. Thank you. As you know, I'm deep into the issue because I've been replying to those letters. So first of all, I think as the FDA, I recognize them as an authority, but if you actually read their memos, their public pronouncements, it's more like trying to scare, or it's not false, but it's also not complete. So if you say that a drug is for animal use, as if you're trying to scare people. Katulad po nung sa nanay ko, parating ko kinikwento to. So sabi ko, ma, meron ako nakitang gamot, baka makatulong sa'yo kasi you're 82 years old, you're diabetic, and there is a surge of cases. So sabi ko, ma, pwede mo inumin mo? Ay, hindi. Narinig ko sa, na hayop lang yan eh. So parang, to me, the statements could also be misleading. They're telling us na the medicine, if we say it works, it could lead to some conclusions that you're protected. At the same time, there are some comments by could also be misconstrued as that's only for animals. The problem is simple. It is not yet registered. Okay, so of course, if it's unregistered, it's illegal, and we don't contest that. We are actually saying that Dr. Landrito tried to register. It is being delayed unnecessarily, and we are contesting that with the anti-red tape authority. and there is an ongoing discussion about that. So, true, it is not registered, but did you do your due responsibility to help it register? So parang may konting half-truth to that. I don't think they did. And their evidence now, yung mga papeles na sinabit ni Dr. Landrito, he submitted way back in February 11, and it's already March. And as if this item is not in the news. In fact, Dr. Landrito and myself were in a meeting around, I think that was March 12. March 12, we had a meeting with the local governors, and we were able to talk to the people in the Department of Health, and they were talking to so they were very much aware that Dr. Landrito is applying. So para namang we were out of the blue, So things are parang I think there's it's not lies, but it's not complete truth.
Okay, thank you, Iggy. Jojo, do you have a view on this? What do you think FDA should do beyond what it's doing already, given the situation?
I think that personally, I believe that the evidence is still lacking. And I reiterate my previous comment that maybe we should reserve judgment. There are, I know, of about 80 ongoing. If you go to clinicaltrials.gov, you will see all the registered clinical trials. And I doubt if, I seriously believe that in the next few months, you will see the results of these. So we've waited a year. What's 2 more months just to be sure? Just to be sure.
Okay. I guess a specific question there is, would any of you recommend that those that are using the drug apply for compassionate use? Because that's the mechanism for it to be used. Apparently, Dr. Landrito has applied, but no action. Should FDA be, urged to act on his application?
Yeah, I'll answer that. Actually, anyone can apply for compassionate. We actually have applied for compassionate use for one of our drugs that we're helping, which is leronlimab. So we're not entirely against compassionate use. However, compassionate use for an outpatient basis, which could be like 5,000 compassionate use applications a day on the outpatient, is actually a bottleneck. And we're happy that it can be done that way. But have you seen the paperwork that would be required? Clinical abstract, 500 pesos to pay for application. So parang hindi yun ang path. So we were hoping a better path, which is sana nga bigyan man lang ng recommendation, but that might be wishful thinking. But right now, our best scenario is, don't warn us doctors how to prescribe. I think we are licensed doctors if we feel that we could offer off-label prescription because of based on our own reading. Sometimes doctors are like that. We can see things that the NIH, the scientists in the so-called ivory tower may not be seeing. Not that I respect them, but siyempre, something the doctors on the ground are seeing. Yeah, I think that's about it.
Okay, thank you. Giselle?
Yes.
Comments at this point? I think we should be winding up, maybe at 10:30.
Yes.
Because not all of the panelists are here, and I think we've pretty much addressed and gotten the answers on the pros and cons.
Can I ask a question?
Yes, please.
Quick
Is this
question,
Ernie?
Dr. Dairit.
Yes.
Ernie?
Yes.
Right.
Yes. Good morning. Sir Vic Ilag was talking about the generation and the multiplication of variants, and it's quite scary. And I think the upsurge now in Europe and in other countries seems to be attributed to this new variants of the COVID. But I don't hear any of these variants, operating in Asia or ASEAN. We are the only country that seems to be getting this upsurge, but not ASEAN, not the other ASEAN countries. How do we explain this, Dr. Dairit?
You know, Ernie, there are a lot of possible reasons for that surge.
Wala kasi sa
Some of
ASEAN
it,
eh. That
well,
is,
you know, some of it could actually have to do with the pandemic control that's happening. Because
yeah.
in the countries in the ASEAN, off the bat, you know, their systems were able to manage any surges of COVID
From the start.
from the start.
Yes.
And so if their systems are holding, then that's indication for why, you know, they continue to suppress the transmission. In our case, we actually have a very, very unreliable and porous pandemic control system.
Yes.
And as you can see, even at the local government level, you know, it's not ideal. And
Yeah.
therefore, it's a combination of all of these things that are causing the surge, including the entry of the variants.
So the Philippines really seems to be punished extraordinarily.
Yeah, and really, because our health systems are quite weak. And I think we have to address that.
And you know, we have a big population, the highest poverty incidence we have in ASEAN, also the highest inequality. It's very difficult for people in a congested, in congested cities like Cebu and Metro Manila to physical distance and also to wear masks that are washed every day, and also to do other protocols, you know, because it's very difficult for them. In a small room, there are 10 people occupying. How can you expect them to be physically distancing themselves? So we are really, you know, so many things are just against us, I think. And of course, we have not addressed this COVID thing early enough, and not really strongly enough. And our spending on COVID has also been the lowest in ASEAN. I have the data, the lowest in ASEAN, which is really a shame, because we have a very big population, as I've said, high poverty incidence, high inequality. So, you know, everything is just militating against us. I just think that is the problem.
Thank you.
Manolete, Giselle here. Thank you for everyone to know this. Dr. Ernie Pernia, Professor Emeritus of School of Economics, UP, and former NEDA Secretary. Thanks, Ernie. I just wanted to call attention to the congressional hearing yesterday. We provided the link, and there, the FDA Director Eric Domingos said that a compassionate use can be applied for and granted within 24 to 48 hours. It's application to a hospital, say, for hundreds of patients. So that was right. I'd like to request everyone to mute. I'd like to request our speakers to go through the chat box and try to reply to some of the questions of our participants. There are many questions and comments on YouTube, and I would appreciate that our speakers might respond to them in the future after this live streaming. And we will be flashing some of the questions now, Manolete, from the chat box, summarized by our PAASE administrator. And just go through this, Manolete, and see what have not been covered by our discussions. Most important would be ways forward. So while going through this, there have been strong suggestions that we try to design and implement a clinical trial for ivermectin, and ask the government to support this or provide a financial support. I would like to ask Dr. Jojo Mantaring whether this is possible at the PGH. At the same time, already make it available to our patients.
So Giselle, you asked a question to Jojo?
I did. I asked.
Yeah, I'm sorry. I didn't hear the question. I think
Yeah,
you
could you repeat
chopped
it?
for a while.
There have been many suggestions, Georgia, that one way forward is, well, to allow compassionate use, say, in PGH, and then to now administer it with a good, well-designed clinical trial. So,
Yes, actually, that can be done. That can be done. But I was going to say, from the ethical point of view, our Declaration of Helsinki, which is like the Bible for research ethics, defines compassionate use as when, especially if the condition is uniformly fatal and there are no other options. So I believe that you can make an argument for compassionate use. As far as doing our own trial, I think that can be done also. Perhaps Dr. Landrito can apply for funding with the Philippine Council for Health Research and Development. And usually the PCHRD can hook them up with epidemiologists or other scientists so that they can be assisted in doing their studies. So it can be done. I'm not opposed to that.
thank you. Jojo, I'm curious, in PGH, are you doing only solidarity trials? Those that are with a solidarity group through the WHO? Do you know? I don't think Jojo got my question. Are there ongoing solidarity trials in the PGH? Also,
There are a lot of trials that are ongoing in PGH. Of course, we're involved in the solidarity.
yes, I understand remdesivir is being used based on compassionate use.
Sorry, you chopped a little bit. I don't know if it's my, let me turn off my video. I lost you, or did you lose me?
You're coming in loud and clear. So Jojo, is remdesivir being used on a compassionate use basis? Manolet, did you hear me?
Yes, I heard you. Georgia, did you hear that? Giselle is asking if remdesivir is being used as compassionate use. I think we lost him.
I think it is. Based on my friends there at PGH, it is.
Yeah,
Okay.
that's Iggy.
Yeah. Sorry,
Okay.
pero kasi but
Well,
I talked to
Giselle,
many.
yeah.
But maybe I could pose a question then, Dr. My esteemed professor. Remember back in the 80s, there was a coconut oil thing by your esteemed father, Dr. Dairit, was a friend of my father. And it was demonized. It probably will just poison people. And there were studies published at the same time. But now, if you look around, it's now well supported that coconut oil is such a helpful thing. And I would like to congratulate Dr. Dairit for having discovered it, at least as one of the pioneers for it. So something might be happening now. That's why I listen to even little signals like this from ivermectin. And I would not want it to be over the counter, but I would want doctors to prescribe it. So for any safety issues or for abuse of it. So science is not perfect. People say that, okay, may lumabas na sa study. Done. Wait after 5 years, more than 20% of the published studies are probably retracted or corrected. So this is always subject to discussion. We are always welcome to studies.
Thank you, Iggy. Giselle, I think
I'm back. I think I got lost.
Yeah, Jojo. Well, the question to you was: But you're not treating COVID patients, but do you know about remdesivir? Is it being used
There are
on a
ongoing.
compassionate basis?
It's under a clinical trial in the Philippine General Hospital.
I see.
Remdesivir.
Okay.
Oh, no. I'm sorry. No. I'm talking about something else. Not remdesivir. And it's not included in the Solidarity trial. There are a lot of trials ongoing. There are a lot of monoclonal antibody trials. Remdesivir is not under trial in the Philippine General Hospital.
Yeah, I think Avigan is still on a pilot study in PGH.
But remdesivir is being used on a compassionate use basis, Jojo.
Yes, it is.
All right. So, well, I would like to recognize two raised hands, but after perhaps a comment on this cost or risk to benefit. Okay, you raised the issue of health risk, toxicity. Okay, I think attached to that would be the cost, the financial cost. Okay, and well, some of you argued that an ineffective medicine is really the most expensive medicine. But then also many people are asking about the cost of ivermectin versus the cost of humanized monoclonal antibodies and remdesivir. And these are available, say, in PGH, in our charity wards as well, but not available in government hospitals in the provinces. So anybody wants to answer that question on cost to benefit, risk to benefit?
Yeah, orthopedic surgeons always do that. We always have this risk to benefit and even cost as we offer surgery to our patients. So this is like very natural to me when I make my assessment to my patients. So certainly remdesivir is there, where the WHO has already said that it does not actually affect mortality, but only shortens hospitalization, but will probably cost you 100,000 pesos. And just for that. And then there's other drugs, I think, steroids being given, but it is not an antiviral. It's really to protect your reaction to the virus. It's not very expensive, but it does have certain problems of making you more prone to infections. And I'd like to offer that ivermectin can also be used. Ivermectin is very, very safe. It only costs, if it's really sold not in larger quantities, it might go down to 20 pesos per tablet. And for prophylaxis, you only need 100 pesos a month. For treatment, you probably just need around 200, 300 pesos. And looking at those, if you offer the patient those options, I think, doesn't it seem parang no-brainer that you would want to try ivermectin?
Okay, Iggy, thanks. Before
Can I
I
comment also
Joe,
for cost?
yes.
Yeah, if a drug doesn't work, then immediately there is a poor cost to benefit ratio, because that means you will be spending unnecessarily for a drug that doesn't work. So before a cost effectiveness analysis can be done, you have to first document that there is effectiveness. If it's not effective, then there
Yeah,
is no need to do a
so
cost
why use
effectiveness
remdesivir?
analysis.
Why use remdesivir? To shorten
Oh,
hospitalization
I,
or, di ba?
I think remdesivir, although I may be wrong, no? I am not an expert on I did not
That's a
really
WHO.
review remdesivir, but
Yeah,
I
it's a
think remdesivir
WHO.
has been found to be the remdesivir has been found to be effective.
No.
So if
I don't think
Short,
remdesivir has been found to be
shorten
effective,
hospital.
then you can do a cost benefit analysis, especially if you're going to be comparing it to other interventions. But
Okay.
just to be clear, you cannot do cost benefit if
Yeah, but I
cost
made it clear.
effectiveness if
I already know how much it works. The WHO has already stated that it should only shorten.
well the
Diba? We follow nga
the
guidelines.
literature does not know.
No,
The
but
literature does not
right now
document
that
yet
is
that
the
it works.
information that we have, and
Yeah,
you have to
I
share
think,
this with the patient.
yeah,
If you don't share that to the patient, that's not also right.
No, excuse me, can I intervene? I think when it comes to health, cost is less a consideration. I think it has what is more applicable in the case of health is risk. If the risk is minimal, then and the benefits, there are benefits. You know, there's a in many cases patients are desperate for some treatment. So I would think that it's okay to take that take the risk of
Yes, sir.
taking that medicine, given the slight risk, and yet the benefits may trump the risk. It's different when it comes to health because, as I've said, people tend to get desperate. It's not like cost benefit analysis of a project, which is not it's not really urgent. It's not to be decided right away. In the case of health, it has to be decided right away. That is my point. So yeah, just to give a nuanced presentation of risk versus benefit on one hand, and cost versus benefit on the other hand. Thank you.
Good point. Thank you so much, Sec Ernie. Before we call the three raised hands, Dulce, then Pox, and then Bernie, Manolet, I would like to again put on the table the issue of ethics. And well, we have heard some people say, is this a case of pro-choice or one's choice? Is that what compassionate use, the relationship between the doctor and the patient, is that what we are going to consider? The advice of the MD on the patient. So before you answer that question, dear speakers, may we hear from Dulce? Keep it short, and then Fox, and then Bernie. You have your hands raised. Thank you.
Okay, my question is, about ivermectin. Kasi, ang sinasabi nila, you cannot dispense it because there's no FDA approval. In the meantime, ang daming taong namamatay. Now, who has already recommended, has already, considered ivermectin as cure for COVID? Nirecommend na nila yan. And then, I don't know who doctor said that wala na yan sa formulary list, no? But yesterday I was, listening to the congressional hearing, and it said it's still in the formulary list. Another thing is, pwede naman gawing emergency use authorization, bigyan sila. Now, we are all taxpayers, okay? Now, we have the right to choose what kind of therapy or what medication we want to have. Now, they should make it available because it's very effective. Na ngayon, yung sinasabi nila, lahat ng studies na nakikita ko at nababasa ko, it's saying 80, 90%, 100% na it can cure and prevent, not only cure, but it prevents the illness. Pagkatapos ngayon, sasabihin, yung studies na ginawa of which our DOH and FDA are a part of, yung mga PMA, etc., sila lang, bugod tangi ang nagsabi that there is no proven positive thing if you take ivermectin, wala raw. And every time they send out an advisory or etc., palagi nilang sinasabi na ito animal use. Now, with regards to animal use, I have two sisters in the United States, and the family, my other sister, they're all doctors, and they say they are taking ivermectin, and in the States, I don't know how true, but I'm just telling you what was relayed to me. In the States, there's no distinction between animal or human ivermectin. Now, the ones available in the drugstore, it's only 3 milligrams. So they take 5. when needed. It's only every 2 weeks or every 3 weeks. So, ngayon sinabi rin, Dr. Cory was in the Senate congressional hearing yesterday. Sinabi na niya ngayon, nag-Senate hearing sila sa Amerika. Pinalabas na niya lahat ng manuscripts, lahat ng studies, lahat magaganda, effective ang Dito lang sa atin yung grupo na sinasabi ni Undersecretary Bergeri, yun ang sinasabi niya na, well, since we are part of this group that is that made a study, yun ang kanilang nakita. It is not effective, it's no positive effect. Bukod tangi sa buong mundo now, billion na ang kumukuha nitong ivermectin. Okay. Bakit sinisingle out ang ivermectin? Ang dami naman dyan. Sinabi na ng recommended na by FDA approved na sa iba. Binigyan pa ng Nobel Prize yung mga nakadiscover na good for virus pala, for treating the virus. Nagkaroon sila ng Nobel Prize. Kukontrahin mo pa yan. Ngayon, sasabihin na pagka it is going to be used for parasites, etc., okay yon. Pero kung gagamitin mo para sa COVID, hindi, dangerous yun. Hindi pwede.
Okay, Dulce, thank you.
Isa lang ang katawan ko.
Pros and cons today discuss. I think you are able to reinforce your views or reconsider some of your views shared with us. Thank you very much, Dulce.
Thank you. Well, I just hope Dr. Calandrito will ask that group that's made the study kung pwede niya makuha yung papeles, how they conducted the study. Sana makuha nila yung resulta nun.
Guidance kahapon. Maraming salamat, Dulce. Si Pox naman. After Pox, 2 to 3 minutes each only, please. Pox. Okay, Pox is not around now. May we hear from Bernie De Jesus?
Yes, I'm here. I have a family, or actually
hello.
two families. Hello, can you hear me?
I'm Pox.
Oh, okay.
I'm Pox. Good morning. Short lang, ma'am.
Go
Hello.
ahead.
Yeah. I just want.
Alika.
Hello.
Titigyan mo ako ng konting adobo. Isang pedaso lang.
Hello.
Yes, Pox, we can hear you.
Yeah, good morning. For Dr. Mantaring, there are already meta-analysis done. 2 meta-analysis done on independent investigators, one by Dr. Tess Laurie and one by the University of Liverpool in UK, and both of them independent research investigators, and they both showed effectiveness of ivermectin. That's said. For Dr. Fontanilla, they keep on saying that the safety is the issue, but there are around 3.7 billion as was said, and it showed no safety. In fact, there are more deaths seen in remdesivir than in people using ivermectin. There are around 417 deaths in remdesivir as compared to only less than 20 for ivermectin. So what safety are you talking about? And then you said that Merck will benefit, and yet Merck company will benefit from if they allowed ivermectin to use. No, Merck will not benefit from it. Why? Because their patents already expired. That's why they will not benefit if they allow ivermectin to be used. And number 2, the cost of production of ivermectin is only 30 cents. How can Merck benefit from it? So there's no issue. And then the third issue that is being said is the overdose of using that was seen in vitro studies, but as what our good doctor from Australia, it said it does not work. The dose that was used in humans are way below the one that was used in vitro studies. And number 3, for our third speaker, Dr. Iggy, I fully agree with you that it is driven by pharmaceutical company. There was a study done in JAMA, if the panel have seen it. They said that ivermectin did not work on patients given with ivermectin compared with the standard of care. But if you look at the authors of that study, the JAMA, that was published March, the authors received grants from, number 1, J&J, which is a maker of vaccine, Gilead, which is the maker of remdesivir, Sanofi, which is a vaccine producer. So all of these researchers who did the JAMA study received grants from these opposing pharmaceutical company who really opposed ivermectin. And the critical analysis of this JAMA study, which is against ivermectin, is that during the course of the study, they changed the objective of the study. It was already documented. Then they did critical analysis of that JAMA study. So it is a bogus study. And the last thing about...
Yes, Fox. We
Yes,
said
po.
3 minutes. You have raised
Sorry.
important
Okay.
point. Let's see if Dr. Jojo Mantaring can reply to it. Your question. Dr. Joy Fontanilla has left because she has clinic. And maybe we can ask some other speakers to respond. Manolet as well. Then we'll go to Bernie. Okay. So anybody wants to reply to the question raised by Pox?
I think the comment raised by Pox regarding the meta-analysis was that he pointed out that there are meta-analyses. There are several already. And the one that I quoted was the one that was done by the Cochrane collaboration. I'm not aware of the other meta-analysis, and perhaps they are more published in websites rather than in the reputable journals. That's all I can say. I acknowledge that there could be meta-analysis, but please keep in mind that not all meta-analysis are done with very good quality. You know,
sir,
there are also what do you call that? Sources of bias, and that's why all meta-analysts have a part of the analysis that looks at risk of bias. I think that's all I have to say.
Yes, thank you. Just one more thing, ma'am. The analysis that was done, they use also the WHO grade and the Cochrane type of analysis. Okay, that's what I want to say. And then lastly, ma'am, lastly lang, one more thing about remdesivir, the solidarity trial that was done by the WHO, because they are talking about the remdesivir. The WHO trial said that remdesivir, hydrochloroquine, lopinavir, ritonavir, and interferon regimens appeared to have little or no effect on 28-day mortality or in-hospital course of COVID-19 among hospitalized patients. This was the WHO publication, the Solidarity Therapeutics Trial. So it means that remdesivir does not work, and yet how come they are using it?
Fox, could you identify yourself and your affiliation?
I'm Dr. Raymond Pesebre. I'm an internist.
Yes. All right. Where are you practicing, if I may ask?
In Bulacan.
Thank you, Pox.
Thank you, ma'am.
Now, Bernie, can you please ask your question?
Can you hear me, ma'am?
Very well. Quickly, please, Bernie.
Okay. I got ivermectin from Dr. Alan, and we have families here who are whole family infected with coronavirus. And we would like to ask, is ivermectin not contraindicated for those with allergy on aspirin, mefenamic, and those who have thyroid problems? That's all my questions.
I base this not on personal experience, but many drugs do cause allergies, and ivermectin may be one of them. But the reported reactions from ivermectin was actually because of parasite death. So the dead parasite is the one causing a lot of the problems, but certainly not excluding the possibility that ivermectin is causing it. Again, that's why it's always good to have a doctor prescribe it to you para lang at least ma-monitor. But can I answer yung kay Pox then, ma'am?
Of course, please.
Yeah. Dr. Pox. Actually, this is also replied to Dr. Mantaring. He mentioned kasi the study by Lopez Medina from JAMA. And I know Dr. Mantaring has been studying this just for a week. So it's unfair to him, because I've seen the Lopez Medina study. And their conclusion is parang the same lang yung placebo with the ivermectin group. And it's a rather big study, but there came a critique to that paper. And unfortunately, na-include nyo sa study nyo eh. So parang meron din palang fault yung pagsala nyo. Nakalusot yun eh. apparently they found out that the problem with that study is that they change outcomes in the middle of the study.
Yes.
Secondly, hindi rin nila nalaman na they're not sure whether even yung placebo nila were not taking kasi maraming over the counter sa Colombia, if I remember right. So among others lang naman. So if I were you, I would remove it as part of those highly selected as if gold standard study. So that's one of my comments. So again, I agree. This is still an ongoing thing. I do not blame Dr. Mantaring, my professor, very competent, but he was not given enough time. Therefore, I give a lot of credence to Dr. Tess Lori. Tess Lori is a professional researcher, highly very, very known for her, and she's been cited 3,000 times. And she does Cochrane reviews, and she gave the meta-analysis. I'm sure I'm not saying naman we're not respected, but sometimes you have to trust in one of them because I myself don't have enough time to do the studies. And she has a number of researchers which she's done over many years already, and yet she recommended it. That's why I feel now, although I haven't really studied each and every one, but she did have an interview. If you watch her interview with the Dr. Campbell, there's a YouTube, an hour of it. You will see things that are not written on published paper. So those are the information I also use. I don't just read journals because sometimes it's a problem. But I agree, it is not a published paper by Dr. Tess Lori. And she does recount how difficult it is to publish papers that are going against the other things. No? Kasi para talaga merong big brother out there that I don't think anyone can deny anymore. Thank you.
From my messaging, I understand Vic Ilag would like to say something. Vic?
So a few things I follow up. I think with POX, that's correct. What I find strange, though, the remdesivir. 3 recent studies for the past month. One in Japan, although it's observational, and Israel, although it's underpowered, but one in India, which was statistically powered. Remdesivir didn't show any effect than placebo. So how come the Philippines make a comment on this ivermectin so focused, so negative, and yet overlooking remdesivir? And actually, why remdesivir doesn't quite perform? It's actually, there's a science, if you look at it how mechanistically, it's injected IV. So that has to travel through the body and then find the target. Once it's in the target, the mechanism, it has to stop every replicating virion, which is probably thousands. So the probability of it working is very unlikely. So that could explain it. Then it could just spray it on your nose. Then in terms of the JAMA article, as Pox pointed out, and I agree with Iggy, I think it's a good read. I'm amazed that that was considered as high quality because this is probably how you should not do a clinical trial.
All right. So, Manolet.
Yes, Giselle, I've actually been listening and absorbing everything that's being said. So
at this point, I think that Vic, Iggy, and Joy and Ben, they're no longer here. And Jojo should get together and discuss this further as a way to move forward. I think my question now is about choice or no choice, pro-choice. May we ask our remaining speakers to again reiterate their advice to us on this?
Shall I start?
Yeah. Beauty before age.
Please.
Thank you, Iya. Ako, ang feeling ko is that, again, I don't think we should pass judgment. Of course, we're all limited by how our information gets to us. What I presented was the information that I found during my review of literature with the help, of course, of the Living CPG group who did the search for me. Kaya you can I wash my hands na I didn't do a comprehensive search because someone else did the search for me. Now the results of these trials, that's a moving target. And for all you know, when the results of the ongoing trials come out in a month or 2 months, and I relook at the evidence, I can change my mind, because what I'm giving now is my opinion based on what I have actually read. So that uh, uh, the evidence is my witness. That's all I can say. I have no personal gain from all of this. I'm speaking for the evidence.
Thank you, Giorgio. For the record, dear audience, I invited Edson Salvania and Tony Dance to participate in this chat, but they said their regrets because of their clinics and their busy schedule. But Tony Dance had actually said, let's wait 28 days for the resolution of the clinical trials. So maybe hear from Iggy and then from Vic.
Yeah, yung is it about choice? Ako, when it comes to that, I'm absolutely saying it's about choice. And I'm a clinician and a surgeon, so never, if you ask any of my patients, have I told my patient that you will die if you don't have the surgery. I always add, if it were true, that you still have a choice. It is your life. There's this Nuremberg agreement, I think, which says that we should respect the body of the patient, and she has the right, she has the right to whatever she puts in there or uses. And of course, it's her consent whether she wants a doctor or not. So in the end, it's the patient first. We are not in control of them completely, but we can, of course, should guide them. And at the same time, I recognize that doctors have rights too. So although FDA, NIH, big groups are recommending things, there's a way of perceiving facts nowadays. It's no longer as simple as I will just read an institutional advice by my great hospital, UPPGH or Harvard. It's no longer like that. The internet has opened up all the scientific data available. It is no longer like I will just check on the Vatican and tell me what they want. No, it's not religion. This is science. It's an evolving thing. So certainly, it should be a cooperation between the patient and the doctor, who the patient himself might be doing the research, sometimes even better than the doctor.
Thank you, Vic. Thank you, George. Iggy. Now let's hear from Vic.
So I cannot comment since I'm a doctor, but probably I think given the differences, opinion, but I think moving forward probably is the best way to look at it. I think, and then to balance the pros and cons. One of the things the US did, I think people last year, sabi nila, you cannot have a vaccine within 4 to 5 years. So essentially, whether you like him or not, they had this Operation Warp Speed. So is it possible to do something analogous for the Philippines, but not vaccines, but something like ivermectin? Since I think there was talk about FDA who start in charge to get everybody sit down, because I agree, I think I have a bit of issue. I think somebody privately manufacturing, why not get the manufacturers on the table, get the government, FDA, and agree on a plan? This is moving forward. So we align and we're going to get it in a certain period of time. Because if you look at the economics of it, as well as logistics, if we're able to get ivermectin to work. This is, and again, I'm not anti-vaccine. I'm for the vaccine. It's long term. But realistically, with the delays and the logistics, looks like they're gonna take longer. And my concern, as I said in my presentation, this virus doesn't care whether we're arguing who's right or wrong, whether we have ivermectin, it's continuously multiplying and mutating. And before we have another one, there's going to be a variant and a variant. So I was thinking, yeah, if we could sit down, I think that would be the best move forward. That would be my suggestion. So put our heads all together, not pro and con, and have something like an operation. What I have in mind is Operation Wormhole, because it's like it forms holes in worms, and it's like we have two realities, that structure which could then bridge that space-time continuum to some reality that we want to be. So yun lang.
Thank you, Vic. I think what Vic is saying is the rules during peacetime do not apply entirely, 100% during the rules during rules during wartime, like this medical war. So I think the MDs, the scientists have to put their heads together, which is what we are trying to do in PAASE with our members and our friends. So Dr. Manolet Dairit and Dr. Vic Ilag are PAASE members. There are many PAASE members in this chat. And one of them, Dr. Alsa Rafika, might still be around, but he also shared the news that a local pharmaceutical company, Lloyd Pharmaceuticals, is waiting for interest from doctors to try to get an LTO, which is required to do the EUA. Am I right, Manolet and Jojo? And the CPR, okay, product registration. So the FDA announced this yesterday. So we must find a way to move forward. And PAASE is there to support our MDs, our mga kababayan in any way we can through science and technology, agham at kaalaman para sa bayan. Maraming salamat for joining us today, everyone. I would have Dr. Manolet Dairit say the last
Can I
word.
have one short comment, ma'am? I'm Dr. Leo Olarte. Can I have one short comment?
Yes, please, Dr. Leo.
Okay. Now, the declaration of Helsinki in 2013 by the World Medical Association says that doctors can prescribe medicines as long as in their discretion it saves human lives, it restores health, and it alleviates pain. Now, that is very important to me. Now, further also, I have learned a lot from the lecture of Dr. Benjamin Ko, former director of the FDA. And he said that Republic Act 9711 is the gatekeeper. Now, all drugs that we have mentioned, we have discussed, they produce adverse drug reactions. There is no one here that is perfect. No drug is perfect. There are always some sort of a adverse drug reaction. Now, my concern here is the lawful exercise of the doctor, the lawful exercise of the clinician in prescribing the medicine. We are all for the best interest of our patients, but we must also think of our own best interest. I am persuaded that ivermectin can save human lives. Now, but I am also concerned of the lawful exercise of the doctor, of his right to give the medicine that is in his discretion and judgment for the best interest of the patient. But most of all, the doctor must also protect himself legally. I have been counsel for a lot of doctors who are defendants, who are accused in criminal proceedings, even if their intention is to help the patient, still they are respondents in a medical malpractice because there is some violation of a law. Now, in this case, there is no much difficulty if those who would like to prescribe ivermectin apply for a compassionate special permit. All requirements are to be complied with by the FDA, and there is no reason why FDA should not grant promptly or as soon as possible a compassionate special permit for the use of ivermectin. Thank you very much for this very important discussion that I have listened. I have learned a lot. My special concern again is for the doctors to protect themselves so that they will not become respondents in any medical malpractice litigation. Thank you very much. I'm Attorney Leo Olarte. I am an MD and I have also a PhD degree. Thank you.
Giselle, just 2 seconds.
Ernie, go ahead.
Yeah, so it looks like scholarly, in terms of scholarly or scientific conclusion, it looks like the jury is still out in terms of scholarly and scientific conclusion. But pragmatically, it's up to the medical doctor, the physician, what to advise in times of emergency and really, a desperate need to, to try to prevent death or, a severe infection. Is that correct? Is that more or less what we can take home?
I think that's a good conclusion, Ernie. And the challenge now is regulatory. And I appreciate the advice of attorney, MD, PhD, Leo Oriates. So I'm sorry that I did not see your raised hand much earlier, but you spoke at the right time. So just as for a wave of optimism, the FDA clarified that there is a way forward. Compassionate use is allowed. And let me tell you on behalf of Alsa Rafika and myself that there is a local pharmaceutical manufacturing company, Lloyd Pharmaceutical, that is waiting for interest from our MDs to manufacture the drug in the right human formulation. But also the human formulated drug is available abroad. Okay, and we do have companies that can source this easily. So I think Dr. Manolet Diary, can you please say the last wise words of wisdom at this point?
Thank you, Giselle. And thank you. Let me conclude by just thanking all of our speakers. Jojo Mantaring, Joy Fontanilla, Igib Agbayani, Benjico, and Vic Ilag. I think you actually contributed a lot to bringing the issues out. So the pros and cons are quite stark. And I think I'll just pick up from some of the comments, particularly, for example, from Jojo, that we shouldn't pass judgment immediately. The results are a moving target, as he said. And, as Ernie Pernia said, the jury is still out, but hopefully we'll get some clear guidance on this going forward. But I'd also like to point out what Iggy Agbayani said, that to a great extent, this is about choice, and particularly choice in a pandemic where people can become really desperate. And if there is just a flicker of hope for something, then maybe people might take that choice. So I think that's also something that we have to put on the table. And then I'd like to take what, of course, Benjico said, and which Attorney Olarte mentioned, is that there are legal processes that we really have to respect. And therefore, we just can't go off our merry way and violate those legal processes, because there could be consequences and lawsuits could be filed. And therefore, in the end, picking up from what the congressional hearing ended up with, I think what we have on the table is an opportunity to really be innovative. And Vic Ilag's comment that we could really bring scientists, regulators, practitioners, manufacturers together to actually work out a plan going forward where we can address the issues of use, where FDA has a word to say about that. The issue about putting a good product on the market, supply, to make it available so that people can have access to them. And of course, choice, so that people can exercise their choice, given that there is access in the market. And I think this is really where our discussion has brought us together. And the way forward is really this innovative action that we have to move beyond the way we do things, bringing out memos and so on and so forth. I think that the main message, if I were just to summarize it in one word, is that we have to get engagement even more effectively among the various stakeholders, the scientists, the practitioners, the manufacturers, and the regulators. And hopefully that dialogue and engagement will bring us to where we can be to help and serve our people better. So with those words, thank you very much. And thank you very much, Giselle, and to PAASE for organizing this meeting. And if there are no other comments, I declare our meeting closed. Thank you.